स्टार्ट करते हैं. Hello, my dear friends. A very warm welcome to all of you. And in this session, we are going to guess the expected question for your upcoming FMGE 2025 January exam. And the method of guessing is very simple. That all the question which has come in last 6 years of NEET and in last 6 years of FMGE are important. In this session, we are going to, and we should focus on those topics which has been asked. So this is the first time I'm telling about ultra important topic. There is nothing like ultra important. Just in any subject, read last 6 years of NEET FMG, whatever question has come, they are the ultra important topic. But you cannot afford to miss this 12, 13 topics which are here. And one by one, we will cover all these topics in our questions. So let's start with doing some question, and then we will also discuss in between how to utilize this last 6 days so that you can ensure to get more than 180 marks in your exam. So first thing is that tuberculin test, they are saying, which is of course a cheap and easily available test, in which situation there is high failure in interpretation of tuberculin test. So when we inject tuberculin antigen in our left arm, we inject it, and after injecting it in left arm, we observe, best time to observe is after 72 hours. We ask the patient to come and show us the swelling, and if the swelling is more than 10 mm, then we say that person is positive. If the swelling is less than or equal to 5 mm, person is said to be negative for TB, and more than 10 mm is positive for TB. In between 5 to 9, if there is any swelling is there, we call it as indeterminate, and we repeat the test. So negative can also be false negative. False negative को कह सकते हैं miss out. मतलब बीमारी है but पकड़ा नहीं गया. The person have the disease but still no swelling came and he came wrongly negative. So it's very easy to remember. False negative occur in those cases for which we think we are negative. Like all of you think you are negative for HIV, at least you think so. So the disease for which you think you are negative, HIV and other immunocompromised condition, that is the case when we get false negative. And false positive comes for the situation for which we all are positive. We all are positive for BCG vaccination. So the disease for which we are positive, false positive. For the disease for which we are negative, HIV, false negative. And this is the way you can remember it very easily. So false positive come in case of previous history of BCG vaccination, recent BCG vaccination. This will give false positive. Now, let's come back to the question and let's understand this point. What they are trying to know is when we will get high failure. High failure means the patient have disease but we are unable to detect it, or we are giving high false positive. False positive matlab we call it also as alpha error p value. बिना मतलब का alert हो गया, बिना मतलब का ही खड़ा हो गया, बिना मतलब का excited हो गया, that all is false positive. Let's say you are giving me report as pregnant, and so that is false positive report you will give to me for pregnancy. That is alpha error, that is p value. We will read about it again in detail. And whenever we say false negative, that is same for beta error, है ना. जब भी हम कहते हैं कि मैं इतनी सुंदर हूं, मैं क्या करूं, है ना. So when we think we are the most beautiful, most attractive, most intelligent, then we overestimate ourselves. We give false positive report. That is alpha error, that is p value whenever we overestimate ourselves. And whenever we underestimate ourselves, कि कोई मुझे प्यार ही नहीं करता, कोई मुझे पसंद ही नहीं करता ना, no one like me, no one give importance to me. When we say things like that, when we underestimate ourselves, that is beta error. And you can understand it in this way that whenever we say non-significant thing as significant, we do alpha error, we overestimate ourselves. And whenever we say significant thing as non-significant, like we all are significant, we all can score good, but whenever we underestimate ourselves, we do beta error. So this is alpha beta error concept also, which we will revise later on. But simply remember, false negative and false positive are the two problems with tuberculin test. And if there is a high percentage of people who are immunized people for BCG. So if people are immunized for BCG, it's very high chance that we will get very high false positive. So if there is high percentage of immunized people, we will get high failure in interpretation of test. If HIV cases are less, that is okay. But if HIV cases are more, then there will be more false negative. So less is okay, more is problematic. And they want to ask in this question, where is the problem? So problem occur if there is high percentage of immunized people. If there is high prevalence of disease, that is a good thing for the test. Then the test, if the prevalence is high, we will discuss it later on, then positive predictive value is also high. Prevalence is directly proportional to PPV. That means more people are disease, more is the chance that test will detect true positive correctly out of total positive. And if environmental mycobacterium infection are less, then that's a wrong thing, which can also lead to more chance of false positive. But better answer is option A. High percentage of immunized people are there, so more chance of false positive, that will lead to failure of tuberculin test. Now there is 2-3 questions which again come from this topic. If they ask, what is the best investigation in case of TB? Best investigation to know spread of TB infection, that TB infection is spreading in community or not. Now infection can only be detected by tuberculin or IgRA. There is only 2 tests which detect infection. Rest all tests, ZN smear, fluorescent microscopy, CBNAT, they detect the disease, not the infection. So when they ask spread of infection in community, we have to detect. So best test will be tuberculin. Interferon gamma release assay is more better test. But the problem with IgRA is that it is very costly. And they have asked this question in NEET 2018 that which test include human blood for detection. So only IgRA in tuberculin in TB investigation need full blood sample. Rest all do not need full blood sample. IgRA need full blood sample. So better answer will be tuberculin will tell about spread of TB infection, and that is detected by annual risk of TB infection, ARTI, which is also known as annual infection rate. Second thing is, what is the best investigation to screen for TB cases? Suppose in your village, you want to know how many people are having TB. So if we are doing screening, we cannot use CBNAT here because CBNAT is very costly and all. So we will use for screening ZN smear we will use. And if I ask what is the best investigation or gold standard for TB diagnosis, gold standard for TB diagnosis is again not CBNAT, because CBNAT overestimate atypical mycobacteria. There are 4 brothers of TB. They are atypical mycobacteria. They also come positive. So gold standard is not CBNAT. Gold standard is culture in liquid medium. Culture in liquid medium. This is known as Mycobacterium growth inducer tube, MGIT tube, in which we do culture in liquid medium, which is the best method, gold standard. So this 3-4 question can come from here. I hope you will remember. And one last thing I want to tell you is that when we talk about ZN smear, we add 3 things in it. They sometimes ask the sequence of it. First we add carbol fuscin, then we add acid alcohol, then we add Loeffler's methylene blue. So you can remember it by this mnemonic. It's Kal. It's Kal mein hum tum kare dhamal. The carbol fuscin, acid alcohol, and Loeffler's methylene blue, the 3 things which we add. And only TB and leprosy, because of mycolic acid in their cell wall, they are not decolorized. They retain the color. That's why they are known as acid loving bacteria, acid fast bacilli, because due to mycolic acid, acid cannot enter in their cell wall and they retain the color. Acid का इस पे असर नहीं होता है, इसलिए ऐसा लगता है कि acid ये का इनसे अफेयर चल रहा हो, प्यार कर रहा हो, और इसलिए इनको एसिड फास्ट बैसिलाई कहते हैं, टीबी और लेप्रोसी को, है ना, because acid do not affect them, so they call it acid fast bacilli. Now what is window period definition? Window period means entry of pathogen and the first detection, first detection of disease, laboratory detection of disease, this is window period. If we talk about first clinical symptom came, entry to first clinical symptom, this is known as incubation period. And sometime even before symptom come, antibodies start developing. So exposure to laboratory detection is window period. Entry to or exposure to first clinical symptom is known as incubation period. Okay, and there are good questions on this topic which I like to discuss here. If they ask this question, that, and they have asked it in NEET exam, that time gap between first symptom and maximum infectivity, इसको क्या कहेंगे ये बताओ. I want students who are seeing my class to answer this question. Time period between first symptom and maximum infectivity क्या कहेंगे? Is equal to, किसके बराबर होगा? Is it equal to generation time? Is it equal to incubation period? Or is it equal to median incubation period? किसके बराबर होगा? Which is first symptom to maximum infectivity? देखो, if they say, if you answer it as, what is your answer? I want to know. Please reply. If you, most of you are answering generation time, and all of you who answer generation time are wrong, because generation time का मतलब होता है time between entry and maximum infectivity. This is generation time. Entry and maximum infectivity. But we are not asking about entry and maximum infectivity. We are asking about first symptom and maximum infectivity. Okay, so generation time cannot be the answer. Now, median incubation period का मतलब होता है that time within which half population get infected is median incubation period. And it is usually found that median incubation period is roughly equal to generation time. So we are not talking about half population getting infected. It is not generation time also. This time gap between first symptom to maximum infectivity is roughly equal to incubation period. It is not the definition of incubation period, but it is roughly equal to that. Let me explain this thing with the help of a story. Suppose, let's say Dr. Arun came and sneezed on me. So after sneezing, entry of pathogen occurred, and then I will start developing symptom, first clinical symptom in, let's say, 2 days. In next 2 days, I will start coughing also. So incubation period is 2 days. Now, in my family, there are actually 10 people live in 3 flats different, and we are big family, 10 people. In next 2 more days, half of that 10 people will get cough cold. So what is median incubation period for my family? 4 days. In 2 days, I started coughing. In 2 more days, half of the family start coughing. Now, it has been found that in the same 4 days, the first person who develops symptom become maximum infective. उसी 4 दिनों में मेरा इन्फेक्शन इतना बढ़ गया कि एक छींकूं और 10 लोगों को इन्फेक्ट कर दूंगा ना. In that 10 days, I became so infective that I can now infect 10 people together in one sneeze. So, entry to first clinical symptom is incubation period, and entry of pathogen to maximum infectivity, this is generation time 4 days. And what is the gap between first clinical symptom and maximum infectivity? आप इस स्टोरी में देख सकते हो कि 2 दिन में मुझे सिम्टम आया था और अगले 2 दिन में मैं मैक्सिमम इन्फेक्टिव हो गया था. तो यानी इंक्यूबेशन पीरियड के बराबर का ही टाइम लगता है पहला क्लिनिकल सिम्टम और मैक्सिमम इन्फेक्टिविटी के बीच में. What I am saying in Hindi was कि you can see in this story that in me pathogen entered 2 days back and first clinical symptom started appearing in 2 days. Then the first person became maximum infective in 4 days. So my generation time was 4 days. And you can see here in this story that the gap between first clinical symptom and maximum infectivity is also 2 days. The gap between entry and first symptom is also 2 days. So we can roughly say that the gap between first clinical symptom and maximum infectivity is equal to incubation period. So don't get confused. If they ask time period between entry and maximum infectivity, this is definitely generation time, entry and maximum infectivity. But if they ask first symptom and maximum infectivity, then that is roughly equal to incubation period. Okay, I hope you agree. If you don't agree, feel free and ask it in the group again. Okay, now let's come to the next question. They are talking about margin of error in the following diagram. They gave 3 diagrams: sample 1, sample 2, sample 3. So when we talk about margin of error or standard error, if you say, this is inversely proportional to precision. Precision का मतलब होता है to the point. If there is more error, data is more scattered. है ना? If there is more error or more standard error, data is more scattered. It is less precise. And precision का मतलब आपको पता है, precision means to the point. Precision means repeatability. Data is coming almost same, is precise. है ना? And in this story, you can see sample 1 is most precise because it is to the point. So why it is most precise? Because probably sample 1 has biggest sample size, because precision or repeatability depend on sample size. Let me explain with an example. Suppose I ask it from a exam going student like you people, and let's say I ask it from my friend who is just going to give this NEET FMG exam, that how much marks you will get in your FMG exam. So he can say that, sir, out of the score of, how much is the maximum score? So there are 300 questions. So out of 300 questions, I will get a score of 180 to 200. This is final exam going student. He said I will get between 180 to 200. And if I ask the same question from a first year student who just entered in, let's say, China or Kyrgyzstan or Russia and going to give the exam, how much marks you will get? He will say, sir, I am 100% confident I will get between 0 to 300. So 180 to 200, he said, I am 95% confident that I will get between 180 to 200. And this guy is saying, I am 100% sure that I will get between 0 to 300, 100% sure. So whose data is precise? Whose data is to the point? Of course, this exam going student data is precise. And why this data is precise? Because this exam going student has given some mock test, has done previous year question, and again he or she is finding it out that my score is coming around 70-80%. So why the student is precise? Because he have observed it again and again. When sample size is more, precision is more. And when precision is more, you can understand that this person has more precision, so you can say that this person has less error. Okay, less error means more precise to the point. And in the second guy case, you cannot even tell this will pass or top, because he had not given any previous year question. So he had no experience, no sample size. And because of less sample size, there is more variation in data, more error, and there is less precision. Okay. So similarly, I hope you understand that as we increase sample size, our precision increase. And precision is the same thing as reliability. You can trust a person when again and again he do the same thing. And when again and again some boy is going on date with the same girl again and again, then only he is reliable. So how you know this guy is reliable? When you observed him again and again, by increasing your sample size. So the point is that in this plot, sample 1 is most precise, so there is less error. And why it is most precise? Because of more sample size. more sample size, more precise. Okay, and less error will be there. So less error will be in 1, then in 2, then in 3. The one sample 2 is here, sample 2 is here and sample 3 is here. So they have confused us. It's not the same order. Let's see it here. What they are trying to give in this, and this is a PYQ, so the exact image can come again also. Focus. Sample 1 is most precise because it is, the answer is coming very close to -1 to +1 to the point. Sample 3 is second number precise. Second precise means second is in, sample third is in between. And sample 2, you can see in the result of sample 2, the data is more scattered. So the more scattered the data is, there will be more error. So sample 2 have most error is in sample 2 because it is least precise, least to the point. So now after looking at the diagram carefully, if you see, most error is in sample 2. Sample 2 has most error, but there is no option which correspond to it because probably in the typing they type this sample 2 as 3 and sample 3 as 2. And this is a typing error which has occurred in recalling or typing the question. But I hope the concept is clear to you that the data which is to the point is most precise and has least error. So least error is in 1. And if this one is sample 2, the middle plot, then sample 2 has some error. But the one which is flat, lowermost, this has most error. So the error, if you want to arrange 3, 2, 1 will be correct. So basically you just have to understand this point that if the data is precise, error will be less. More precise, error less. And that's why plot 1, sample 1, which is most precise to the point, has least error. And precision is directly proportional to sample size. Now we can understand this thing and we can use it in another 2 questions which has came in recent NEET exam, that when we talk about confidence interval, what is confidence interval? Confidence interval is simply that range of data within which answer lies. वो रेंज जिसके अंदर आंसर छुपा है वो कॉन्फिडेंस इंटरवल है. जैसे जब आपने से पूछा मैंने कि कितना नंबर लाओगे, आपने बोला 180 से 200, यानी ये कितना हो गया 190 प्लस माइनस 10. ये आपका 95% कॉन्फिडेंस इंटरवल है. When I ask you and you said I will get between 190 plus minus 10, you were 95% confident. So this is your 95% confidence interval. Confidence interval is just वो range है जिसके अंदर आंसर छुपा है. It is just that range within which answer lies. So answer lies between 180 to 200. So your confidence interval is 180 to 200. Now the question they ask is which type of confidence interval is better? Is it big confidence interval which is more significant better, or is it less confidence interval which is more significant? So remember this point, confidence interval is smaller the better. Smaller confidence interval is more significant data. And you can understand it with the above example. When I was talking about with final exam student, his confidence interval was 180 to 200 small. And his data was more significant. It was clearly indicating he will pass with good marks. But in case of second student, who is first year student, his confidence interval was very big. So his data was almost non-significant. So smaller confidence interval, more significant data. Now, second question which came from in NEET exam from this point is, how can you narrow the confidence interval? So remember, to make the confidence interval more precise, more narrow, we have to increase the sample size. Okay, so to decrease, how will you decrease range of confidence interval? To decrease range of confidence interval, we have to increase sample size. Okay, so this 2 question has been asked in PYQ. Do remember it? और याद रखना मेरे दोस्तों, हमें जिंदगी में बड़ी चीजें पसंद होती हैं. हम कहते भी हैं बड़ा है तो बेहतर है, लेकिन 2 चीज जो सी से होती हैं वो छोटी होनी चाहिए. कौन सी 2 चीज? एक है कॉन्फिडेंस इंटरवल और दूसरा है कोएफिशिएंट ऑफ वेरिएंस. दिस 2 थिंग दे स्टार्ट विथ सी and we say big is better, but for these two things, smaller means more significant. A smaller coefficient of variance or smaller confidence interval means more significant data. Okay. So we will talk about coefficient of variance later on. I hope confidence interval point is clear, and I hope you all know that when we talk about 68% confidence interval, the formula is mean plus minus 1 standard deviation. When we talk about 95% confidence interval, the formula is mean plus minus 2 standard deviation. And from this topic, they ask this question that how much area belong to mean plus 1 standard deviation. Mean plus 1 standard deviation में कितना area आएगा? Option A, is it 0.47? B, is it 0.68? C, is it 0.34? D, is it 0.95? I want all of my friends to answer this new question which I just put here, that how much area belong to mean plus 1 standard deviation. Let me write the options better. A 0.47, B 0.34, C 0.68, or D 0.95. Which one will be in mean plus 1 standard deviation? Try to answer it. So I hope you all know that if this is a standard normal curve, in the standard normal curve there are 3 rules. First rule is in the center there is 0 and topmost point is the mode. Mode is always on the top of curve. And like I am a model and you can see my curve coming out top. So mode is always on top of curve. This is a rule. And the middle number is the median. So we can have minus 1 standard deviation here, minus 2 standard deviation here, minus 3 here, and plus 1, plus 2, plus 3 there. The rule simply says that first and foremost, do not forget this point, that mean, median, mode all are equal to 0. I hope you know that. But they mostly ask question from second rule. The second rule says that area under curve is equal to standard deviation, and this is equal to variance, and all are equal to 1. Sabka Malik Ek. This is what every good religious people said. Krishna said, Muhammad Paigambar said, Sai said, Guru Nanak said that all religion is one, God is one, we are unnecessarily fighting. So this is rule 2 from which they ask question mostly. Third rule is what I have written, that 68% value lie within mean plus minus 1, 95% within mean plus minus 2, and 99% within mean plus minus 3. So now come back to my question, how much area belong to mean plus 1 standard deviation? How much area belong to mean plus 1 standard deviation? Alakes Kaushik, Meera Lakshmi, Rajat Srivas, Lavanya Veluswamy, Hemant, and all of them has given correct answer. Wasifur Rahman has given correct. Anjali Ahuja has given correct. It is 0.34, not 0.68. Why not 0.68? Because 0.68 is minus 1 to plus 1. This whole area is 0.68. And we are not asking mean plus minus 1. We are only asking mean and plus 1, half of the area. And half of 68 is 34%. So if they ask area belong to mean plus minus 1, 0.34. If they ask area outside mean plus minus 1 standard deviation. So within mean plus minus 1, 68% value are there. Outside means 100 minus 68. So outside mean plus minus 1, if they ask, it is 32%. Within mean plus minus 1, if they ask, it is 68%. But if they ask only mean plus 1, not plus minus 1, then answer will be 0.34. Okay, I hope this is clear. Now coming to this next very good question, that a 18-year-old male come with pruritus over hand, itching over hand. You can see the image. What is the causative organism shown here? I hope you can understand and identify it very easily. It is Sarcopittus scabies. Sarcopittus scabies question will have 3 type of hint in it. First hint is other family member also have itching. If they give it other family member also have itching, it is definitely scabies. Second hint is they can write about inguinal area or interdigital web space area. So inguinal or this फोस्टा एरियाज है ना, बगले जिसको कहते हैं ना, इन सब एरियाज में जो खुजली होती है ज्यादातर वो स्केबीज है. एंड ऑफ कोर्स व्हाट इज द ड्रग ऑफ चॉइस? द ड्रग ऑफ चॉइस इज 5% परमिथ्रिन. which we have to apply all over body, not just over the area with itching. So this is definitely Sarcoptes scabies. Genophycelia cheopis is the other name of rat flea. And rat flea, it carry the causative organism for bubonic plague. So what is the causative organism for bubonic plague? That has been asked in one of the NEET question, that a patient come with inflamed bubo. What is bubo means? Bubo means lymph node. So patient with inflamed bubo came. What is the causative organism? Causative organism is Yersinia pestis. So Yersinia pestis is one disease. Second disease is Hymenolapsis, which is transmitted by rat flea. Third disease is endemic typhus. And endemic typhus is also known as murine typhus. So how to remember this four thing? To remember this three disease, actually, we can use the mnemonic BHAME. You can imagine this as rat flea, and there will be this image of rat flea, which is better to show you if it is there. Let me check it out. So if you can see rat flea, and if you can see, there is no image for that in my iPad. So if rat flea image they gave, think that there is rat flea. I hope you have seen this is like a flea with this 4-6 hand also, like it's a normal insect. And imagine the Chota Bheem is sitting over it with his gada in his hand. This is Chota Bheem sitting over rat flea. And why, if you remember this image in your mind, you can always remember it. And why I made this mnemonic Bheem? Because Chota Bheem is our local endemic hero of India. So Chota Bheem, Chota Bheem is endemic. So endemic typhus is by rat flea or by, the causative organism for endemic typhus or murine typhus is Rickettsia typhi. Again, you can think it like this. Typhoid is endemic in India. So endemic typhus by Rickettsia typhi is transmitted by rat flea. And when we talk about epidemic typhus, epidemic is big thing. So epidemic typhus, the causative organism is Rickettsia prowazhaki. Power hai iske andar. It's prowazhaki. Power is there. So due to this power, epidemic typhus is, and what is the transmitting agent who transmit epidemic typhus? So epidemic typhus is transmitted by louse, head lice. So louse transmit epidemic typhus, prowazhaki. Power is there. And endemic is typhoid, endemic typhus transmitted by rat flea. And Chota Bheem is the mnemonic to remember the four diseases transmitted by rat flea. Tell me, who is the girlfriend of Chota Bheem? Chota Bheem is very sharp, is having two girlfriend. Anyway, so we will talk about louse and other diseases later on, but let's revise it here only. When we talk about louse, there are four diseases transmitted by louse. One is pediculosis. Other is, we just read, epidemic typhus, pediculosis. Then the second is epidemic typhus. Epidemic, not endemic, epidemic typhus. Then there is relapsing fever. And the fourth disease is trench fever. Do remember, trench fever is same as Quintana fever. So this question came once in MCI exam, who transmit Q fever? And I also thought answer is air. Q fever transmitted by air actually. But if they ask who transmit Quintana fever is same as trench fever. And trench or Quintana fever is transmitted by louse. Why trench fever is known as Quintana fever? Because the causative organism is Bartonella quintanax. So Quintana fever, trench fever. And these four are transmitted by louse. Now, how will you remember it? Remember your childhood days. When you used to take out head lice from your head and kill it, it used to produce a sound of put. So the mnemonic is also for louse, put. P for pediculosis, E for epidemic typhus, R for relapsing fever, T for trench fever. So I hope you will remember louse and rat flea disease, and remember the difference of endemic, epidemic typhus, because very commonly they create this question in the exam that a human came after bite, he had fever and rash, what is the causative organism? That is mostly Rickettsia prowazhaki. When they talk about human bite with insect and then fever and rash, mostly they are talking about epidemic typhus. Okay, and causative organism is prowazhaki. So now let's do this one question where they ask you to find out which type of data is there. Is it nominal, ordinal, ratio, ordinal, qualitative, nominal, or continuous? Which type of data is there? So they are talking about child. Chutki is the girlfriend of Chota Bheem, was Mayank Hemant answer. Is it really Chutki or Indumati? Chota Bheem has extra affair also. Very sharp-minded. Anyway, so Meera Lakshmi want to say that, can you explain again, please? Which thing you want to explain, dear? I just, okay, let me explain again. I just told you that if they ask this question, that there is a human with bite from insect, and after having bite from insect, they have developed rash and fever. So, okay, so if they ask this question, bite with insect, rash and fever, in 90% cases, they are talking about epidemic typhus disease. And if they say epidemic typhus, who is causing it? Caused by Rickettsia prowazhaki. And they can ask who is transmitting it. So if they ask who is transmitting it, answer will be louse. So you have to remember this thing. That's, I think, is the thing which you wanted to know. If it is clear to you, my dear friend Meera Lakshmi, let me know. If not, do tell me. Okay. Dinu Punia is asking me to teach in Hindi. Dear, if anything is not clear in English, you can always tell. But let's go in it because it's mostly question answer only. So, and just so even if anything is not clear, let me know. चलो बिड़ू देखो, अभी इस तरह के जब हम लोग क्लासिफिकेशंस को देखते हैं, स्केल को देखते हैं, तो यहां किस टाइप का डेटा यूज कर रहे हैं? विच टाइप ऑफ डेटा वी आर यूजिंग? यू कैन सी सम नंबर हेयर, बट दिस नंबर is artificially put. This is not quantitative or continuous. When we say quantitative or continuous, quantitative continuous is something which we can measure. Liver disease we cannot measure. Liver disease we can only classify into category. And when we classify into category, we call it qualitative or categorical, because we can classify them into category. But categorical data is of two type. Categorical or qualitative data can be either nominal or ordinal. Ordinal means there should be some order between them. Like in the childbirth classification, if it is coming 10 to 15, then liver disease is more serious. If it is coming 7 to 9, liver disease is mild or moderate. 5 to 6 is normal. So we are arranging them in order. That's why it is ordinal. And do remember this point, that whenever they talk about any scale, any score, all scale or score are ordinal. They ask this point again and again. Like they will ask Glasgow comma scale, ABKI score, depression scale, any score, everything is ordinal. What is nominal? Nominal can be anything which is just name, cannot arrange. For example, if I ask about sex, you will say done it or not done it, kiya nahi kiya, or you will say male, female, transgender. So it's just name. You cannot say that male are stronger than female or female are stronger than male, because strength depends in your mind. So we can only name them, not arrange them. That's why they are nominal. Just like sex, there is blood group. Just like sex, there is race, religion. All are just nominal. So nominal, ordinal are qualitative, and here we can arrange them in order. So the better answer is ordinal. This is an ordinal data. Nominal will be blood group, race, religion, sex, all these things. When it comes to continuous data can be either interval or ratio. Interval are those data which exist at 0. For example, Many of you have experienced 0 degrees Celsius in your life. Most of you have experienced. So when there is 0 degree, does temperature goes away? No, still it is still there. So example of interval is temperature. Temperature in degree Celsius or Fahrenheit, क्योंकि 0 डिग्री आने पे टेम्परेचर गायब नहीं होता है, तो जो 0 पे गायब नहीं होता है उसको इंटरवल कहते हैं. Those who do not vanish at 0, they are interval. And how to remember it? See, before Corona, all our vacation are either summer vacation or winter vacation. So who gave us interval of life? Temperature gave us interval of life. So interval, who gave? Temperature gave our vacation or interval. And ratio include every other thing which are vanished at 0, don't exist at 0. For example, if you are measuring BP at emergency room, your senior asks, what is the BP? And you said, sir, BP is 0. What does it mean? It means patient has flied away or the tube is not connected with the machine. So BP don't exist at 0. Weight don't exist at 0. Height don't exist at 0. So these are ratio and interval is temperature. Okay. So I hope you will understand these two things separately. Whatever we can measure is quantitative. Quantitative is measurable. And measurable data can be interval or ratio. Whatever we can categorize is quality, category, and qualitative can be nominal or ordinal. Now, let's do one more question and then we will go to understand chi-square, paired, unpaired, and all those tests. So all of the following are continuous variable except. Continuous means quantitative, and continuous or quantitative means whatever we can measure. Like weight we can measure. Blood group we cannot measure. Blood group we can only categorize into different group. So it is categorical, and categorical also it is nominal. So blood group is not continuous. Age and height we can always measure. So these are continuous or quantitative. Now, why this classification is important to understand? Because when we talk about categorical or qualitative data, and there is qualitative data of 2 or more group. In this case, 2 or more group qualitative data if they give, we will simply apply chi-square test. So if in any question they give qualitative data, apply chi-square. And what are qualitative data? Suppose I am talking about my obesity. Is it measurable or is it categorical? So obesity is quality. तुम कह सकते हो कि मोटे तू थोड़ा मोटा है, बहुत मोटा है, फटने वाला है ना? Mild, moderate, severe obesity, or you are about to burst out. That's what you can say. But you cannot say that you are 2.8 obese. You can measure my BMI. You can measure my weight. So BMI and weight, these are continuous, but obesity is qualitative. Similarly, in last MCI exam, they asked, what is cholesterol? Cholesterol is quantitative or qualitative? So please answer it in the group. Where will you put cholesterol? Cholesterol is quantitative or qualitative? Do tell me. Here, BMI weight is qualitative. BMI weight we can measure, whatever we can measure is quantitative. Similarly, if we say height, measurable. If I ask you, where will you put hypertension? Is it quantitative or qualitative? Hypertension we cannot measure. What we measure is BP. So BP is quantitative. Hypertension is either mild, moderate, or severe hypertension. So hypertension is qualitative. And where will you put cholesterol? Very good. Ashima, Rajat, Srivastav, Nisa Pandey, Danish Asim, Anya Yogesh, thank you for replying. Of course, cholesterol we can measure. So cholesterol, bilirubin, they will go here. But when they talk about liver failure or any cancer staging and all, they all will be qualitative. Because simply, just remember this one point simply, that if they talk about any disease, डिजीज इज ऑलवेज क्वालिटेटिव। जितनी बीमारियां हैं सब बीमारी को नाप नहीं सकते हैं, बस कैटेगरी में बांट सकते हैं, इसलिए बीमारियां सारी की सारी क्वालिटेटिव हैं और बीमारियों में जिन चीजों को नापते हैं वो क्वांटिटेटिव हैं। ऑल डिजीज आर क्वालिटेटिव, द पैरामीटर विच वी मेजर इन दैट डिजीज इज क्वांटिटेटिव। ओके, like hypertension, obesity, all are qualitative. If I say anemia, where will you put anemia? I hope now I understand. Anemia is qualitative because anemia we can only say present or absent or mild, moderate, severe. So anemia is qualitative, but HB will be, we can measure. So HB is quantitative. So if they ask question in which you have to compare obesity, hypertension, anemia or any disease, answer will be directly chi-square test, because chi-square test is for categorical qualitative data. And do remember one more thing, extra thing, that categorical or qualitative data is in percentage or proportion. Because if I am asking about how many of you will have anemia, so I can say 5 out of 100 have anemia. 5 out of 100 means proportion. I can also say it 5 out of 100 means 5%. So percentage proportion is for qualitative data. And similarly, median and mode is also for qualitative data. Whenever we talk about quantitative data, mean is for quantitative data. Because I can measure mean weight of the class, mean hemoglobin of the class. But I cannot measure mean anemia people in the class. I can measure percentage of anemia. So percentage for qualitative, in any question if they give percentage or disease, it is directly chi-square test. Median, mode, chi-square test. And when it comes to quantitative data like BMI, weight, height, then in the continuous or quantitative, we first have to see, are they using the word pre and post test data? Pre and post test can also be called as match data. This can also be called as before after data. If they use the word pre post, before after match, in this case we will simply apply paired t-test, and paired t-test is also known as dependent t-test. If they talk about two groups, and in the question they did not use pre post match data, before after data, only they write two group, we will apply unpaired t-test. And unpaired t-test is also known as independent t-test or student t-test. Okay, I will explain it with example and we will do many questions on it, but this is the area from which 2 questions came in NEET exam recently, so we have to make it sure that we have a solid control over this area. And when there is more than 2 group, 3 or more group, and the data is quantitative, then we apply ANOVA. ANOVA means analysis of variance. So how to decide which test to apply? Very simply, पहले ये देखो क्या क्वेश्चन में किसी बीमारी का नाम, परसेंटेज, प्रोपोर्शन का नाम लिखा है। अगर है तो आंसर chi स्क्वायर हो गया। फिर ये देखो कि क्या क्वेश्चन में प्री, पोस्ट, बिफोर, आफ्टर मैच वर्ड लिखा है। अगर है तो आंसर पेयर टी टेस्ट हो गया, डिपेंडेंट टी टेस्ट हो गया। और अगर 2 ग्रुप है तो इंडिपेंडेंट, अनपेयर्ड, स्टूडेंट टी टेस्ट, 3 या 3 से ज्यादा है तो एनोवा हो जाएगा। लेट मी एक्सप्लेन दिस थिंग्स विथ एग्जांपल। सपोज दे सेड दैट you found a new drug to treat my obesity and you gave it in one group of people and another group of people you gave old drug Orlistat, and then you are comparing that after taking medicine percentage of obese people is only 20% in your new drug and 80% in old drug. So which test you will apply? What we are comparing? Percentage of obesity. Obesity is a disease, qualitative data, percentage is qualitative data. When we are comparing percentage of obese, we will apply chi-square test. But if they change the question and ask it that in the 2 group, we are measuring their weight before giving drug, after giving drug, but what we are measuring is weight. Weight is quantitative, we can measure weight. So whatever we can measure, BMI, weight, height, these all are quantitative, and they have measured it pre and post, before, after giving drug. And because before, after coming from the same person, so that's why it is known as paired. Because before weight, before giving drug, weight, after giving drug, weight are of the same person. So pre-post is the area where we apply PLT test. What is match data? If you are giving your new drug to 32-year male and you are comparing it with Orlistat, the old drug, to a 32-year male. So 32-year male, both side, this type of data is match. मैच का मतलब होता है लगभग मिलते हुए लोगों को दोनों तरफ लेना. Almost similar type of people in two group is match data. So if they use match pre, post, before, after, you will apply PLT test. If they say in the two group weight is taken but not pre, post, only weight is taken two group, answer will be unpaired or student T test. If they said weight is taken in three group, one group who get your new drug, one group Orlistat, one group who did just exercise, no drug. So three group is there and weight is measured. And not pre-post, only weight is measured. This time we will apply ANOVA. So in this way, we can understand this 4 tests very simply. And now let's practice some question on this topic to make it more clear. This is one question. I hope you will understand it. A study was conducted with the objective to compare the incidence of postpartum depression. I want all of you to reply here like you all are doing already. Very good. Postpartum depression. And you are using a depression score. So depression in mother depends on the sex of the child. One group with female babies, one group with male baby, you are comparing their depression in the two group. Now which test should we use? So first thing is, can you answer it? Lavanya Veluswamy answered it as chi-square. Mayank Goswami and all are answering chi-square test. Okay, Karun Takran, all of you are mostly answering chi-square. Very good. First thing is they are talking about depression, and depression is a disease. As soon as disease come, disease is which type of data? Qualitative. And in case of qualitative data, we apply chi-square test. Simple. You just have to see what is the outcome. Outcome is depression is there. How much depression is there? When they are talking about how much depression, they are using a scale, and we just discussed that all score and all scale are ordinal data. So when they talk about depression score also, this is ordinal. And ordinal and nominal are qualitative data. So although there is a number, but that number is just forcefully given to arrange them in order. And ordinal data, qualitative answer is chi-square. Okay, very good. You understand the thing. You have to see what is the outcome. हम नाप क्या रहे हैं, compare क्या कर रहे हैं, वो देखना होगा. और compare करने वाली चीज अगर बीमारी है तो आंसर chi-square हो जाएगा. What we are comparing, that we have to see, and if it is disease, answer is chi-square because it is qualitative. Let's do one more question. In a study, 2 groups of newborn are checked for their weight based on whether their mother received food supplement or not. The appropriate test which can be used for comparing the data is, some of the good app has given wrong answer to this question also. So let me see whether you can do it correctly or not. What we are measuring? First of all, this time which test you will apply? Sahu is saying love you, sir. Love you too, Sahu. See you soon, buddy. Yeah. So do try to answer which test we apply here in this case. First of all, they have clearly written there is 2 groups. One group who are taking food supplement, one group who are not. Second thing to see here is they are measuring for their weight. They are measuring their weight. And weight is which type of data? Can we measure weight? Yes, that's written also, it is measuring weight. So weight is quantitative. And if it is quantitative, chi-square is gone. Because chi-square is not for quantitative. Second thing, have they written we are measuring weight before giving food, after giving food? No. Because it is birth weight. Birth weight cannot be measured before birth and after birth. So it's not before, after, pre, post, match word written. If these 3 were not written, paired t-test gone. And they are measuring weight in 2 group. So whenever there is 2 group and weight, answer become student t-test or unpaired t-test, and that is the correct answer C, which most of you has given also. Very good. Dinupunia, Dr. Irresistible, Anna Sweta Sinha, Rajas Srivas, Samser Ali, Vrunda Patel, all of you are giving correct answer. Very good. What is Fisher exact? Fisher exact is same as chi-square. Fisher exact we apply when sample size is less than 30, and chi-square is X. Who comes first? F come first or X come first? F come first, na? So sample size is less than 30. X come late. So it is one with sample size more than 30. So in any question, they never give you sample size. So in none of the question, Fisher exact test is the answer. Fisher exact test kabhi answer nahi hoga, kyunki wo sample size denge hi nahi. Therefore, always the answer is, if it is qualitative data, the answer will always be chi-square. But here it is quantitative, so answer is not chi-square, answer is student t-test. Okay. Chalo. So I hope this topic is clear to all of you. If you still have some confusion in identifying the test, feel free to ask the doubt. Now, let's come to this question. The best study design to access the, so let's find out this question, how to decide whether to apply case control or cohort or cross-sectional. The best study design to assess the association between smoking and lung cancer in relatively quick time. Which study design is preferred? So, if we want to get the answer in quick time, cohort study and RCT cannot be done in quick time. Cohort study need to do follow-up longer duration, and RCT need to do randomization, then observe them in future. These are not done in quick time. Answer will be either case control or cross-sectional. And when you look at evidence-based medicine, I hope you know what is evidence-based medicine. It simply means that while taking decision for patient, we use the data of study and then decide what is best for the patient. Like you cannot enter into a ward and say, give cow urine to every patient. Unless you yourself had drink cow urine and found it is useful, or there is a scientific research on that. You cannot say that drink cow urine. And you cannot say that stop giving guava, apple, banana in evening, it causes cold and cough. Without data, you cannot say it. And in the evidence-based medicine, the strongest evidence, best evidence come from meta-analysis. Not meta-analysis, meta-analysis. Second number evidence come from systematic review. After systematic review, the third number evidence come from RCT. Fourth evidence come from cohort. Fifth come from case control. After case control, there is cross-sectional. Ecological people don't put in this list, because when we do ecological study, ecological is done on whole population, and rest all study is done on individual. So ecological you can remove from the list also, because it is on population, not on individual. And after ecological, we can have case series. And then finally we have case, after case series there is case study. And after case study we have the final thing, expert opinion. Last, least importance is given to expert opinion. That means do not trust on anything which I am telling you, because I am just an expert and expert can be wrong. What is case study and case series? Case study is one patient hospital story. Suppose you are doing surgery and one night a case of penile fracture came to the emergency, and you write a detailed thing about the patient, how you did Doppler and how you did surgery. One patient, that is case study. And suppose your paper became famous and you are being called in Delhi to repair 3 penile fracture here, and you are called to Dubai to repair 4 penile fracture there also. Al-Habibi. So now you are writing about 7 patients of 2 different groups, but they have the common disease, and you are writing their complete hospital story. So this is case series. It is more than one group of patient, one or more group of patient, but they should have common disease. Okay, so their disease should be common. And remember, this case study, case series, both are example of observational descriptive study, because there are 2 types of study. One is in which you do some fingering, some experiment. आपने कुछ किया, कोई दवा दी, कोई सर्जरी दी, that is known as interventional. An interventional study is only RCT. In RCT only, we give some medicine or do something. Rest all study are just observational. इसलिए इसको कहते हैं धृतराष्ट्र स्टडी, है ना? धृतराष्ट्र कैसे कहते रहता केवल पूछता था ये क्या हो रहा है, ये क्या हो रहा है, कुछ करता नहीं था, है ना? Dhritarashtra was a blind character in Mahabharata who just keep asking what is happening, what is happening. He don't used to intervene. So similarly, in observational study, we don't intervene, we just observe. And in observational descriptive study, we only write the story, describe the story. So observational descriptive is case series, case study. And cohort and case control, these two are observational analytic. Why they are observational analytic? Because in cohort case control, we also get data. And with the data, we can analyze the story also. So I hope it is simple. अगर सिर्फ कहानी है तो ऑब्जर्वेशनल डिस्क्रिप्टिव, अगर कहानी के साथ डेटा भी है तो ऑब्जर्वेशनल एनालिटिक. If it is only story, it is case study, case series, observational descriptive, otherwise cohort case control, which are observational analytic, and RCT interventional. So this is the evidence-based medicine sequence. Now, case control and cross-sectional both can be done in quick time. But out of case control and cross-sectional, which one is above? Of course, case control is above cross-sectional. So which one will be better to do a study on smoking and lung cancer in quick time? The better answer will be, of course, case control, because it is above cross-sectional and case control can done quickly. Okay. Now, second question is again from the concept of evidence-based medicine, that which study is best to evaluate effect and outcome? Is it clinical trial? Is it cohort? Is it case control or cross-sectional? Which one is better? So to decide which one is better, you have to follow the sequence of evidence-based medicine. And in the sequence of evidence-based medicine, cohort is above case control and cross-sectional. But above cohort, there was RCT. Can you see it? RCT was above cohort. So out of these four, which one is better to evaluate effect and outcome? Clinical trial will be much better, because it is above cohort, case control and cross-sectional. Okay. But in the same question, if they have given meta-analysis or systematic review in the option, that would have become better answer. But because meta-analysis, systematic review is not there, so answer is clinical trial. Now in the same question, if I change the question and I ask best study to know natural history of disease. Now, as soon as people see natural history, they think history is there, so answer is case control, because in case control we take history. No. Natural history means temporal association. And natural history or temporal association means cause precede effect. परिणाम से पहले कारण. Cause means कारण, reason, exposure, and effect means outcome. So the reason occur before outcome. परिणाम से पहले कारण, है ना? कारण पहले फिर परिणाम, है ना? Cause is first, then there is effect or outcome. So these three things are the same thing. And all these three things, naturally, if you want to know why someone is doing accident, like my younger sister Mona used to do a lot of accident. So if I want to know naturally why my younger sister is doing accident, the best way is to follow her. But there was no other scooty, so I sit in her scooty and try to find the reason. And then we were crossing one bridge and there was a cycle man going. I asked her to put the brake. Mona, brake lagao. And but she was saying that I am putting the brake, but still she hit that cycle man. So then the real reason is that her hand was small and she was not able to hold the brake properly. So the accident was occurring. So how I know the real reason? How I know the cause which occurred before accident? By following her, by sitting in her own scooty, by following her. So whenever you follow someone, you know the natural history properly. And follow-up is done in cohort study. That's why cohort study is known as follow-up or longitudinal study. Because in this, we follow them up. So which study is best to know natural history, temporal association or cause preceding effect? Then the answer will become cohort. Here we will not follow the sequence of evidence-based medicine. Here answer is cohort. And do remember, there was a scientist Hill who said that if two things are occurring together, it doesn't mean one is causing the other. And he gave Hill criteria of association. And in Hill criteria of association, there is total 9 factors, which you need not remember. Just remember that in Hill criteria of association, sensitivity is not a criteria. Specificity is a criteria, but not sensitivity. For example, scrotal cancer, है ना, अखरोटों का कैंसर, है ना, टट्टों के कवरिंग का कैंसर, testicular scrotal cancer, they mostly occur in chimney viper of coal tar factory. So it is specifically occurring in them, those people. केवल उन्हीं में हो रहा था, specifically occurring in those. That's why it is showing association. But sensitivity is not a criteria of association. Specificity is a criteria. Sensitivity is not a criteria. And in the Hill criteria of association, what is the most important criteria? Most important criteria is temporal association. That's why they ask this question again and again, and that's why I took this time to discuss it again. Most important Hill criteria is temporal, and temporal association means cause, precede, effect, natural history of disease. Okay, so now let's go to after evidence-based medicine. Let's try to understand how to decide when we apply case control, when we apply cohort. Let's try to decide that. So a study was conducted in 3 villages with 3 different water sources, and prevalence of typhoid carrier was studied in this 3 villages. What type of study is this? So can you answer me this question? This is a twisted one. Can you answer this? Which type of study is done here? Dr. Ronak Karwa has a question that, sir, kindly discuss cohort and prospective cohort. So there is 3 types of cohort which we will discuss in with example, but cohort is same as prospective cohort, because in cohort we go in future. Future means prospective, आगे जाना, prospective. So cohort or prospective cohort is the same thing. They are the same thing. And in cohort or prospective cohort, we know the exposure, but we don't know the outcome. कारण होता है, परिणाम अभी नहीं हुआ होता है. Exposure is present, outcome is absent. Okay, this is prospective cohort. The question which probably you were willing to ask is, what is the difference between cohort and retrospective cohort? It's a very good question being asked again and again in NEET and ICT, and this is one area where I am expecting that MCI will ask question this time. Retrospective cohort. Retrospective is same as historical cohort. Okay, so in retrospective or historical cohort, there will be a hint in the question. They will write that based on written work record or based on written data, they are making some comparison based on written record or work data. Let me explain this part. Suppose, let's say, my dear friend Dr. Positivity is in the group. He is too positive for his future, so he prepared well, gave the exam well, and he got radiology branch. After taking radiology, he is giving a big party, and his neighbor Majnu Bhai came in the party and said, why are you giving this party? Don't you know that based on written record, work record data of past 10 years, radiology staff has 1.2 times more risk of testicular cancer as normal staff. So, तेरे टट्टे खतरे में है, your testicle are in danger and you are giving party. So what he's saying, he's just comparing past 10-year work record data of radiology and other staff. So this is which type of cohort? This is the retrospective cohort. In this retrospective or historical cohort, you can see when we started the study, exposure was present and outcome was also present. कुछ लोग पहले से ही radiology department में काम कर रहे थे और उनमें से कुछ को पहले से ही कैंसर हो चुका था। तो कारण और परिणाम स्टडी के शुरू होने से पहले ही दोनों चीज मौजूद थी। When the study was starting, some people had already cancer and some people were already working in the radiology department. So exposure and outcome both were present at the beginning of the study. This is the difference between a normal cohort and retrospective cohort. Now suppose Dr. Positivity, he took radiology. He said to Majnu ki jalta hai Majnu. Majnu is just jealous. Did not focus on them. And he took radiology. After taking radiology, he did 3 years of cohort study in the future. And along with 3 years of cohort study, he also used data of the past 10-year work record. So he is, after doing this study, he finally found that relative risk is coming 1 and there is no significant association. So what he is doing? He is doing mixed cohort. भाई पॉजिटिव भाई आगे भी जा रहा है, पीछे भी जा रहा है. He is going in forward, doing 3-year cohort and using last 10-year work record data also. So both direction, that's why mixed. That is why the other name is ambispective cohort. Ambispective means again both direction, future and past. And the third name of mixed cohort or ambispective cohort is nested case control. देखो इस बात को ध्यान से समझो. असली टफ काम है 3 साल फ्यूचर का डेटा लेना. उस 3 साल के डेटा में पिछले 10 साल के वर्क रिकॉर्ड डेटा जो एक टाइप से निकल सकता है ना, एक कंप्यूटर पे क्लिक दिया और 10 साल का डेटा आ जाएगा, काम का डेटा. तो पिछले का डेटा लेना मुश्किल काम नहीं है. मुश्किल काम क्या है? 3 साल आगे का डेटा लेना. 3 साल कोहॉर्ट मुश्किल है और उस कोहॉर्ट में पीछे के 10 साल के डेटा को घुसा दिया गया. तो घोंसला बना लिया. किसने घोंसला बनाया? पीछे के डेटा ने, केस कंट्रोल ने घोंसला बनाया. किसके अंदर? कोहॉर्ट के अंदर. इसलिए नेस्टेड केस कंट्रोल भी कोहॉर्ट है जिसमें पीछे के डेटा को घुसा देते हैं. What I was saying in Hindi was that along with 3-year future data, he also used 10-year work record data. Which one is more difficult to collect? More difficult to collect is 3-year future data because past 10-year data is available in computer. Just by one click you can get the data. So main is cohort in which past data is inserted, nested. That's why it is nested case control or inserted case control in cohort. So nested case control is not case control. It is also cohort in which past data is nested, inserted. घोंसला बना लिया, घुसा दिया, inserted. So this 3 will have 2 parts. One thing is there will be future follow-up, and along with future follow-up, they will also write past written record. So if you found both words in the question, past written record plus future follow-up, that is mixed cohort. And if you found only one line past written record, then it is retrospective cohort. सिर्फ written record past data है, retrospective. Written record के साथ future follow-up भी है, mixed हो गया. And to remember them separately, you can use the mnemonic RH positive man. R and H used for retrospective historical, and man is used for mixed, ambispective and nested case control. Man. And you can know man. Man can go any direction. So man is mixed, ambispective, nested, and RH positive is for retrospective historical. So these are 3 types of cohort. I hope you will remember it. I am willing to give you some question to practice this 3 types of cohort, and then I will come back. The question is not in this, of course, the TND session. So I have to go to my main slides, class slides. There I will find the question and then I will ask it from you people. So let's do some question from here. Remember this point that when they talk about retrospective cohort is only using past written record. But when they talk about mixed cohort, along with past written record, there will be future follow-up also. So let's do these 2 questions. This is a question. Can you do it? Question is, bladder cancer is found 9 times more common in worker as compared to staff of aniline dye factory worker based on 20-year past work record data. Which type of study is it? Is it retrospective cohort, option A? Is it nested case control, option B? Is it cohort or is it case control? So my dear friend, in this question you can see this clear word written, work record data. whenever you find work record data, answer is either nested case control or retrospective cohort. Because in case control, we take personal history from case and control. केस कंट्रोल में पूछते हैं बीमार और नॉन बीमार लोगों से कि पीछे में क्या हुआ. So personal history is in case control, not work records. So case control is not there. And in cohort, we do follow up. And in this question, we are not doing follow up. So because we are not doing follow up, only work record data, answer is retrospective cohort. I hope it is clear. Now let's do the above question. This was actually a question of INICET exam. We took 10,000 mother, we gave them a questionnaire about smoking and other habits, है ना. हम पूछे कि क्या तुम सुट्टा पीती हो, क्या तुम दारू पीती हो, तुम एक्सरसाइज क्यों नहीं करती हो, ऐसे ऐसे सवाल पूछा. And after asking this question, we collected the questionnaire data and then we did 6-month follow-up study. After delivery, after 6-month follow-up, we finally concluded the result. And in the result, we use past written record plus future follow-up. So there is written data also, there is future follow-up data also. Both the things are there. You can see we are doing follow-up and we are using written data. If both the things are there, answer become nested case control. If there is only written data, answer is retrospective cohort. If there is written data plus future follow-up, answer is nested case control. And because in nested case control, we are going in both directions. So this is the way to decide this type of study. And I hope this retrospective cohort and other thing is also clear to all of you. Okay. Now let's coming back to our question discussion session. And I hope you will remember this 3 type of study. This is a very good area to focus. Now let's come back to our original question. The question was that a study was conducted in 3 villages and they are asking in them how many people have typhoid. घूम घूम के पूछ रहे हैं कि क्या आपको छरछरी हो रही है. छरछरी is the musical sound which comes out when you have loose motion. Do you have loose motion? We are asking from everyone in the villages. So we are asking question from everyone and we are trying to know prevalence, ki how many people are having typhoid right now. So answer to this question is cross-sectional study. In cross-sectional study, we collect prevalence. That is why cross-sectional study का ही दूसरा नाम है prevalence study. Cross-sectional study is known as prevalence study or snapshot study. Why they call it a snapshot study? Tell me, can you take picture in future or past? No, you can take picture only in present moment. So like that, cross-sectional study is only done in present moment, that how many have typhoid. Okay, so this is a prevalence study. But in the same question, if they took 2 groups, one group who are carrier and one group who are case of typhoid patient. So typhoid patient or case, carrier can be used as control and they can ask the past history that from where you drink water. So if typhoid and carrier are 2 groups in the beginning, answer will become case control study. And if in that case control, they would be asking the past history that where were you drinking water from the past. But if they want to make this same question as cohort study, then the 2 group will be those people who are drinking well water from the village and those people who are not drinking well water, they are drinking RO water or some not from well and not drinking well water. So drinking well water, not drinking well water, it represents the 2 group in which exposure is present or exposure is absent. एक ग्रुप है जिसमें कारण है और एक ग्रुप है जिसमें कारण नहीं है. कारण है, कारण नहीं है, अगर 2 ग्रुप होगा तो आंसर है कोहॉर्ट. अगर 2 ग्रुप है जिसमें बीमारी है, बीमारी नहीं है, तो आंसर है केस कंट्रोल. Karan means exposure, risk factor. So if the 2 group is exposure present, exposure absent, it is cohort. If the 2 group is disease present, disease absent, then that is case control. Okay, so exposure present absent is cohort, disease present absent is case control. So in the same question, I hope this three thing is clear to you. When do we answer cohort? When it is exposure present absent. When do we answer case control? When it is disease present absent. And when we ask question from everyone about present moment prevalence, answer is cross sectional. Okay, chalo. Now let's come to the next question. Head-on matrix is related to which thing? Head-on matrix is a 3x3 table which we draw to prevent road traffic accident. This is for injury prevention. Okay, we just try to know what are the reason before accident, in whether the driver is sleeping well or not, and then during accident, and then in the hospital what reason occurred which lead to accident. So this is 3x3 table to know the causes of it. So that is injury prevention. Okay. Now let's move ahead and let's discuss this question. Which type of data description is given here? Is it a stem and leaf plot diagram, box and whisker diagram, forest plot, funnel plot? Can you answer it? Which type of diagram is here? So if I draw this thing and then put the two tail, this is the box, and this box start from 25% to 75%, and this is whisker. Whisker का मतलब होता है tail, पूंछ. So this is box and whisker plot, and if any number is outside, we call it outlier. So box and whisker plot, why we draw it? Box and whisker plot identify outlier. What is outlier? Like every 2-3 years they do this study in UK that how many sexual partner you had lifelong, and usual answer come 2 to 7. But in the same UK population, some hunter people give the data, I had 699 sex partner, 554, 438. So if you give this type of weird data, that means you are an outlier. Should we include those 699 hunter? उन शिकारियों का डेटा आम जनता में इंक्लूड करना चाहिए या नहीं करना चाहिए? Should we include those extreme 699 hunter data into normal population? No, because they are very extreme. They will affect the average of the population. So we can remove them by calling them outlier. So they are outlier. This is detected by box and whisker plot. Forest and funnel plot, these two are drawn in meta-analysis. In meta-analysis, we collect the data from different study and we plot them together. So in the exam, if you got a plot with this type of thing and dots within it like this, this is funnel plot. And forest plot look like this. Like forest plot will be something like this. There will be this one central line with odds ratio equal to 1. And then there will be some line which will be here, some line which will be crossing it, some line which will be on this side only, or some line which will be on this side only. So this type of plot will be forest plot. And they can ask you that out of this 4 study, suppose this is study 1, this study 2, 3, 4. How many study are showing positive association? How many show positive association? This image-based question are being asked this day. So when they talk about positive association, I hope you all know positive association will come out when odds ratio and relative risk is more than 1. More than 1 is positive association. And in this diagram, we are representing confidence interval in odds ratio, suppose. And confidence interval is here, it is not touching this central pink line. So here it is 1.1 to 1.4 positive association. In line 2, it is 0.7 to 1.2. 0.7 to 1.2 include 1. And odds ratio 1 means no association. So if the confidence interval include 1, if confidence interval include 1, this means study is non-significant. देखो, मान लो कि हमारे दोस्त तुलिका ने मेडिसिन ली और डीएम कार्डियो कर लिया ना, डीएम कार्डियोलॉजी एंड फाउंड ए न्यू ड्रग टू लोअर बीपी, and she is writing that one time when she give her drug, BP becomes 0.7. 0.7 is odds ratio less than 1. Less than 1 means no association. So when Dr. Tulika is getting very sorry, no association is odds ratio of 1. If odds ratio is less than 1 means there is negative association. Negative association means if you take Dr. Tulika drug, BP will reduce. है ना? Negative association means more drug, antihypertensive drug, and less will be the BP. So this is negative association in opposite direction. We can also call it protective association. Negative is known as protective, and we will get negative or protective association whenever odds ratio or relative risk is less than 1. Less than 1 is protective. So here, when Tulika is giving her antihypertensive drug and BP is coming 0.7, it means more drug, less BP, protective. When it is coming 1.2, we discuss it that whenever it is more than 1, we call it positive association. So that means you took Dr. Tulika drug and BP can increase also. So if the same medicine is lowering BP and increasing BP, it means the medicine is not related with BP. Okay. So when it is 0.7 and 1.2, 0.7, 1.2 means it can sometime lower BP, sometime increase BP. And if it can lower or increase BP both, it means this medicine is non-significant. तो क्या आपको बात समझ में आ रही है? एक इसको सिंपल एग्जांपल से समझ लो. मान लो हम लोग बात कर रहे हैं दूध और सेक्स की, कि दूध से सेक्स बढ़ता है कि नहीं, है ना? हनीमून नाइट में पिला देते हैं केसर फ्लेवर्ड, टर्मरिक फ्लेवर्ड. तो अगर एक बार आया कि दूध पीने से सेक्स 0.7 हुआ, घट गया क्योंकि ब्लड सप्लाई पेट में चली गई, उस ऑर्गन में गई नहीं जहां जाना था, और अगली बार आया कि दूध पीने से सेक्स बढ़ गया, तो अगर सेम दूध से सेक्स घट रहा है, एक बार बढ़ रहा है, यानी दूध सेक्स से रिलेटेड ही नहीं है ना? कुछ और बदल के देखो, है. सो if in the same medicine, or let's say with the same drug, one time BP is lowering, one time BP is increasing, it means the drug is not related with BP. If with giving milk sometimes sex decrease, sometimes sex increase, it means the milk is not related with sex. So if the confidence interval include 1 means non-significant. Always remember. So study 2 is non-significant. Now study 3, you can see it start from 1.1 go to 1.4 or 3. So study 1 and 3, how many show positive association? Positive association, पहली study दिखा रही है, first study and third study is showing positive association because they do not include 1. Okay, if it include 1, it become non-significant. But when it comes to study 4 को देखो, this one, this green one. In the study 4, you can see it start with 0.7, end at 0.9. So 0.7 to 0.59 means negative association. So study 4 is also significant but negative. How many show positive association? 1 and 3. 1 and 3, 2 studies show positive association. Second study is non-significant because it include 1. And last, fourth is negative association study. So this type of plot is forest plot, and they can ask this image based question also. Okay. So this is, I think, clear. If it is not clear, feel free to ask. So this is forest and funnel plot, which we draw in meta-analysis. Box whisker is simply different. And this image is of stem and leaf diagram. And this is stem and leaf diagram plot, which is drawn here. What I am drawing here is, let's say, your weight. If your weight is 53, in the class, some people weight is 53, some people weight is 68. Some people weight is 79, and some people weight is also 69, and let's say they are doing 69 also. So the last number become leaf. Like here, last number is 3, it become leaf. 8 become leaf. 9 become leaf. And this 9 become leaf. Last number become leaf. And remaining number like 5, 6, and 7, this will become a stem. And we will arrange them. So this is stem and leaf diagram. And what is the use of stem and leaf diagram? Stem and leaf diagram tell exact distribution. exactly how the data is going. This is what stem and leaf plot tell. Exact distribution is by stem and leaf plot, and you can easily identify these 4 images. I hope it is clear. Stormbreaker is saying crystal clear, sir. Okay, very good. So now let's move ahead and discuss this one new type of question. Patient has diabetes and hypertension, both came to your clinic, and as a doctor you have to explain the risk of various complications. Which tool you will use to demonstrate? Pie chart, histogram, scatter plot, Venn diagram. So see, this patient has hypertension. Due to hypertension he can have renal failure. Due to hypertension he can have MI. Due to hypertension he can have stroke. Okay. Now, due to diabetes, again, diabetes also can cause renal failure. So let's remove renal failure from here. Hypertension is causing this too, and hypertension is also causing renal failure. Diabetes is also causing renal failure. Then diabetes can also lead to cataract. Diabetes can also cause neuropathy and all. So if the patient come with BP, sugar and not taking the medicine regularly, you can explain it to the patient that, my dear patient, due to hypertension you can develop these 3 problems. You can, and due to diabetes you can develop these 3 problems. But if you don't take medicine, your kidney will definitely very high chance of failing, and there is very high chance of this microvascular growth in retina, and that can lead to blindness. So you can become blind and your kidney can fail for sure, because both this cause this complication. So this type of diagram is known as Venn diagram, and Venn diagram help us to explain combined risk, and this combined risk of 2 things are explained through the help of Venn diagram. So if patient has both, what you will use? Venn diagram. Okay. What is a scatter plot? A scatter plot is simply the dots plot. That is scatter plot. Like I can show you this thing, that if the if let's say the BP is more, then the chance of MI is more, like this. This type of dot plot is a scatter plot. And what does a scatter plot tell about? A scatter plot tell about correlation. Correlation is direction of association between 2 variable. 2 चीज का डायरेक्शन क्या है वो कोरिलेशन बताता है. जैसे यहां पर बीपी बढ़ने से एमआई बढ़ रहा है, तो उनका डायरेक्शन पॉजिटिव है. So correlation tell about direction of association, and the direction here is positive. Now what is histogram? Histogram like this, they can say that if the CRP level rises, if the CRP level is less and then it is increasing, the risk of MI is increasing with CRP level. So this type of diagram is histogram. MI बढ़ा, CRP बढ़ा. So we can say that MI and CRP are rising together, but we can't say that MI is due to high CRP. ऐसा तो कह सकते हैं कि MR हार्ट अटैक और CRP साथ में उन दोनों का रिस्क ज्यादा है, लेकिन ये नहीं कह सकते हैं कि CRP बढ़ने के चलते हार्ट अटैक आया. We cannot use the word due to. We cannot say that CRP is causing MI, because in Hill criteria we discussed correlation does not imply causation. If 2 things are happening together, it doesn't mean one is causing the other. Let's say someone is in love. Let's say my dear friend Muhammad Anas is in love, and while falling his love, his marks is increasing. So people will think that both marks is increasing due to love, but only the room partner of Dr. Anas know that since Dr. Anas has fallen in love, he stopped watching all those Netflix and Prime Video web series, and he is giving that time in study. So marks is increasing not due to love, marks is increasing due to more hour of study. So remember two things, you cannot say due to. You can say that they are correlated, but you cannot say that one is causing other. And this type of plot is histogram. If I took the middle point of all the bar of histogram and I join it, and I suppose I join it, then on joining it, this type of plot which will come out with sharp turn, this type of plot which has dots in it, come by joining midpoint, this is known as frequency polygon. And frequency polygon is formed by midpoint, and it is usually having sharp turn. You can see the dots in it joining the line. This is frequency polygon. So you know scatter plot for correlation, histogram, frequency polygon. Pie chart, I hope you know, is circular, and this question has came in MCI exam also. Which diagram we can use to explain balanced diet to layman. So if you want to explain balanced diet to layman, then we can use pie chart. In the pie chart, we can draw a circle and we can simply say that 50-70% should be carbohydrate, then 15 to 30% can be fat, and 15 to 20% can be protein. So carbohydrate, fat, protein, like that you can explain with pie chart. So these are the data representation method. I hope you will remember it. Let's come to do some other question. The question is that if the mean systolic blood pressure was measured in a sample of population of elderly female and came out to be 125 with a standard deviation of 10, 95% people would have BP above what? So whenever they talk about 95% people, it means we have to find 95% confidence interval. And they will give you a numerical on confidence interval, very likely this exam. Because last two exams, they are giving 4 or 5 numerical in FMGE exam. So this time they will probably give you numerical on this pattern, 95%. So in the 95%, we all know the formula. It is mean plus minus 2 standard deviation. And what is the mean value here? The mean value is 125. What is the standard deviation here? Standard deviation कितना दिया हुआ है? 10. तो इसमें कोई कैलकुलेशन है ही नहीं, बहुत सिंपल है. आपको बस 2 into 10 कर देना है और 125 में से 20 माइनस कर देना है, 20 प्लस कर देना है. You just have to do 2 into 10 standard deviation and subtract it from 125 and add it. So it will become 105 to 145. This is the 95% confidence interval. Now the question they are asking is, where will you find 95% people? Is it 105? Is it 1010, 110, 115, 114? I want you all to give answer. 2 of you have given answer 105. But the correct answer is never 105. 105 is wrong answer. Manikant Statistical is saying, sir, please explain previous question. Why not, Manikant? In the previous question, I was just telling you that if patient came with both hypertension and diabetes, you have to explain the risk of various complication. So to explain them the risk of various complication, the better diagram will be Venn diagram. Venn diagram is something like this, like what I draw. Here in the Venn diagram, we explain the combined risk better. So this is Venn diagram. And along with Venn diagram, I gave you some example of histogram. Here is histogram, CRP and MI. A scatter plot which represent correlation is here. And pie chart, you all know, it can be used to explain balanced diet to layman, is shown above. So these are the common image-based question which come from diagram. Manikant Tandal, is it clear or not? Do let me know. Surya series, is it clear or not? समझ में आ रहा है कि नहीं? क्या कहना चाह रहा हूं मैं? वेन डायग्राम इतना कुछ नहीं है कॉम्प्लेक्स, आप समझ जाओगे. बस एक नई चीज होती है ना तो दिमाग रोकता है, लेकिन ये है बहुत सिंपल. बीपी शुगर दोनों है मरीज को, हाइपरटेंशन डायबिटीज दोनों है. आपको कंबाइंड रिस्क समझाना है, किस डायग्राम को यूज करोगे? तो कंबाइंड रिस्क समझाने में वेन डायग्राम बेटर होगा. To explain the combined risk, Venn diagram is better, because hypertension will lead to some complication, diabetes will lead to some complication, and there will be some common complication with them, like renal failure, retinopathy. These are common. So we can explain it with this type of diagram, this type of circle making and explaining complications. This is Venn diagram. Okay. आई होप इट इज क्लियर। अच्छा, स्टैंडर्ड डिविएशन वाला नहीं क्लियर होता। स्टैंडर्ड डिविएशन वाला तो अभी समझा रहा हूं मैं, अभी तो मैं समझा रहा हूं, आई एम जस्ट एक्सप्लेनिंग इट। इन दिस क्वेश्चन दे वर आस्किंग 95% people will have blood pressure above what? We know 95% confidence interval is 105 to 145। ये तो सिंपल है। अब देखो इस 105 से 145 को प्लॉट करके देखो। लेट्स ट्राई टू प्लॉट 105 to 145। If you will plot it, this is the mean 125. 105 is, let's say, somewhere here, minus 2 standard deviation, and 145 is here, plus 2 standard deviation. So we all know between 105 and 145 95% value lie. So if 95% are inside them, how many are outside 105? Outside 105 cannot be 5%. See, if you subtract 95 from 100, it will be 5% which is outside. But that 5% will not go in one side, na? They will be divided into 2.5% here, 2.5% here. 95% के बाहर 5% लोग हैं, तो वो एक ही साइड तो नहीं जाएंगे, वो 2.5% दोनों साइड जाएंगे। तो आपको देख के ही पता चल रहा है कि 105 से नीचे कितने लोग हैं? 105 के नीचे केवल 2.5% लोग हैं। यानी 105 से ऊपर कितने लोग हो गए? 105 से ऊपर हो गए 97.5% लोग। और क्वेश्चन में ये पूछ रहा है कि किस वजन के किस बीपी के ऊपर 95% लोग होंगे, और यहां पर कितने लोग 105 से ऊपर हो गए? 97.5%। What I am trying to say in Hindi was that if you remove 95%, the remaining 5% will get divided into two half, and therefore below 105 there is only 2.5%, or outside 105 there is only 97.5% people, not 95% people. So 105 is not the answer. What is the answer? Just above 105 whatever is given, 105 के जस्ट ऊपर जाके देखो कौन सा ऑप्शन है 105 के जस्ट ऊपर? 110। अगर आप 110 पे गए तो 110 और 105 के बीच में आपको 2.5% लोग मिल जाएंगे, ऐसा उम्मीद लगा सकते हैं। अब देखो 110 के नीचे कितने लोग हो गए? 110 के नीचे हो गए 5%, तो ऊपर कितने बच गए? ऊपर बच गए 95%, क्योंकि 100 में से 5 हट गया, 95 बच गए। तो करेक्ट आंसर है 110। 110 के ऊपर 95% लोग होंगे, क्योंकि 110 के नीचे 5% है। What I was saying in Hindi was that if you move a just bit above of -2 standard deviation, just above -2 standard deviation, 5% people lie। 95% people कहां लाई करते हैं? जस्ट above -2 standard deviation। जस्ट above -2 standard deviation जो नेक्स्ट वैल्यू दिया होता है उसके ऊपर 95% लोग होते हैं, बिकॉज जस्ट above -2 if you will go, let's say you go from 105 to 110, there is a probability that between 105 and 1010 you can find 2.5% extra people. So now 2.5 and 2.5 total 5% are below 110, therefore 5% are below it, out above it will be 95%. So what is the answer in such question? If they ask about 95% or if they ask about 5%, answer is just above -2. Just above -2 is there in the answer. Okay, let me explain it with one more question so that it become more clear. An example make things very clear. So let's do one more question here. The question is that in a class, in your class, suppose average weight of a student is 70 kg and standard deviation is 10 kg. So where will 95% above which weight, है ना, ये पूछ देंगे ऐसे कि above which weight 95% student weight will be there. क्लास में एवरेज वेट है 70, स्टैंडर्ड डिविएशन 10, above which weight 95% student will lie. 95% बच्चों का वजन कितने से ज्यादा होगा? So in this question, first step is find 95% confidence interval. What is that? Mean plus minus 2 standard deviation. Mean is 70 plus minus 2 into 10. अगर आप करोगे तो कितना आ जाएगा? 50 to 90. Now if you plot 50 to 90, between 50 to 90, 95% people are there. We all know that. So how many are below 50? Below 50, 2.5%, above 90, 2.5%. This is the way we plot it. Below 50, between 50 and 90, 95%, 2.5, 2.5, above. So, in the option, suppose they gave 50 kg, 53 kg, 47 kg, like that they can create option. तो आपको क्या करना है, 50 kg है, -2 स्टैंडर्ड डिविएशन आपको पता चल गया है. अब -2 स्टैंडर्ड डिविएशन के जस्ट ऊपर जो भी नंबर दिया है, जैसे यहां 50 से ऊपर जस्ट ऊपर क्या दिया है, 53. आप 53 पे जाइए तो ऐसा चांस है कि 50 और 53 के बीच में 2.5% लोग और मिल जाएंगे. तो यानी 53 के नीचे अब कितने लोग आ गए, 5%. और 53 से ऊपर कितने बचे रह गए, 95%. क्योंकि टोटल 100% लोग हैं. अगर 5% नीचे हो गए तो 5 खत्म होने के बाद कितने बच गए, 95 बच गए. तो जो आंसर -2 स्टैंडर्ड डिविएशन से जस्ट ऊपर वाला ऑप्शन जो भी होगा उसी पे 5% या 95% लोग लाई करेंगे. सो व्हाट आई वाज सेइंग इन हिंदी वाज, दे आर आस्किंग वेयर 95% स्टूडेंट विल लाई, एंड 95% स्टूडेंट आर नॉट बिलो 50 or not above 50, because below 50 there is only 2.5% people. So above 50 this is 95 plus 2.5, total 97.5% people are above 50. So answer cannot be 50 kg. Answer is the one which is just above 50. Just above 50 option is 53. If you go just above 50 till 53, there is a chance that between 53 and 50 you can find 2.5% extra people. So if you found 2.5% extra and you add them, 2.5% between 50 and 53, 2.5 between less than 50. So total 5% people are below 53. And if 5% are below 53, it means 95% are above 53. So answer is not 50. Answer is the one which is just above -2 standard deviation. You have to choose the number which is just above -2 standard deviation, and that will be the correct answer. Okay, so this is a tricky type of numerical, but it has already been asked in previous year, so it can again come. This is the exact language of a PYQ being asked on this topic. I hope you understand it. If it is not clear, feel free to ask it again. Chalo. So do remember how to find 95%, but do remember if they ask where is 5% or 95% people lying, then you have to go just above -2 standard deviation. Okay. So next question, which of the following is used to compare two data sets taken on two different scales of measurement? Answered is coefficient of variance. When we want to compare quality of two data set, quality or dispersion of two data set, we use coefficient of variance. Okay. For example, some students say that INICT is more tough than NEET exam. So INICT and NEET, they both are two different pattern of marking. NEET exam, there is 1/4 negative marking, INICT 1/3 negative marking. So their scales of measurement is different also. Now, if you want to compare their score, we can compare them through coefficient of variance. Let's say there are 3 students who got in NEET exam, out of 100% marks, they got 50%, 60%, 70%. And in INICT, suppose someone got 55%, 60%, 65%. So here the negative marking is different, pattern is different. If they want to know the coefficient of variance, Coefficient of variance is standard deviation by mean. This is the formula. Standard deviation simply means how far is each number from the middle number. How far is 70 from 60? 10. How far is 50 from 60? 10. So standard deviation is 10. Standard deviation का सीधा मतलब है हर एक नंबर बीच के नंबर से कितना दूर है. 70 60 से 10 दूर है, 50 60 से 10 दूर है, तो स्टैंडर्ड डिविएशन 10 है. And mean is average. And if the data is symmetrical, every number is equally away, then middle number is the mean. So here mean is 60. अगर नंबर बराबर दूरी पर है तो बीच का नंबर ही मीन होता है. आप निकाल के देख लो, आएगा 60. So because it is symmetrical, mean is 60, it will come 1 by 6. This is coefficient of variance for NEET exam. But coefficient of variance for INI-CT exam, if you will calculate 55, 60, 65, here standard deviation by mean, standard deviation is how far is each number from 65, how much is mean? 65 by 60, or you can say 1 by 12. So 1 by 12 is here, which is less. 1 by 12 is less, and less coefficient of variance, as I said, more significant data. हमने बात करी थी ना कि हमें जिंदगी में बड़ी चीज चाहिए, लेकिन दो चीज जो C से है वो छोटी होनी चाहिए. Coefficient of variance and confidence interval. We want big thing, but two things with C should be smaller. Coefficient of variance and confidence interval. Less coefficient of variance, more significant data. So which data is better? Second data is better. How we compared it? We compared it with the help of coefficient of variance. So do remember, this question has been asked 2 times in NEET exam already. To compare quality or dispersion of data set of 2 different scale, we use coefficient of variance. Okay, dear. Chalo, so this is there. Now, Manikant is asking, what about 68 and 99%? My dear, 68%, we use find 68% with the help of mean plus minus 1 standard deviation. And when they ask 99%, we calculate it with the help of mean plus minus 3 standard deviation. And here in the question, they are only asking that 95% people will lie there. So if they are asking about 95%, we just have to use the formula of 95%. We don't need to use the formula of 68 or 99 here. Hai na? We will use the formula for 95, which is mean plus minus 2 standard deviation. And we will calculate that answer. Okay? Feel free, ask me. Chalo, now let's move ahead. And Dr. Guiding Hand Consultancy is getting naughty and he's asking, what about 69%? They will ask 68 or 95 or 5, but not 69%. This is a matter of equality which you have to maintain. Okay. Chalo, come here. So this question has already been asked. They are saying that there are 4 studies with correlation coefficient of 0.6 each. So what is the final or net correlation coefficient? Correlation coefficient हमें बताता है strength of association. Coefficient correlation tell us how strongly 2 things are related. Strength of association. And we decide correlation coefficient based on their average distance from an imaginary central line. Imaginary central line से डॉट कितने दूर हैं, उसी बेसिस पे coefficient of correlation डिसाइड होता है. और क्योंकि हर एक चारों स्टडी में इमेजिनरी सेंट्रल लाइन से डॉट 0.6 दूर है, हर एक का कोरिलेशन कोएफिशिएंट 0.6 है, तो फाइनल कोरिलेशन कोएफिशिएंट भी कितना होगा? 0.6 ही होगा. बिकॉज इन ऑल द 4 स्टडी डॉट्स आर इक्वली अवे and by their distance from imaginary central line we calculate correlation coefficient. So in all the study the dots are almost equally away. Final correlation coefficient will also be same as correlation coefficient of all the 4 study. So it will be 0.6. One more type of question they can ask from here is, if they give a dots which are far apart, this is plot A, dots are far apart, dot B, dots are closer to each other, they will ask which has a stronger correlation coefficient. इसका बड़ा होगा correlation coefficient. Which one has a stronger correlation coefficient? So because in one dots are far away, so correlation coefficient will be less, 0.5. In B dots are close, so correlation coefficient will be more, 0.8. So which has a stronger correlation coefficient? That is B. But if they give an image with dots exactly on the center line, then R is perfect one. So stronger correlation coefficient will be C, and after C there is B, then there is A. Dots are far apart, less correlation coefficient. In one exam of INICET, they gave an interesting question. They created dots like this, going above and then coming down. So if it is going above, R value is plus 0.9 because positive correlation. If the dots are going down, R value is minus 0.9 because it is in a negative direction. So final value of R will be roughly 0. It's the thing which occurs with cigarette smoking and age. With age, cigarette smoking increases, then decreases. But it doesn't mean that at 20 years, cigarette will come automatically in your mouth. You have to make the decision. So cigarette smoking is related with age, but the correlation coefficient is almost 0. It depends on your friend circle and other things. Okay. So do remember this 3-4 question which came on correlation coefficient. And do remember correlation coefficient tell about how strongly two things are correlated. Okay. Now, what is the most cost-effective method of infection control? This is definitely hand washing. Hand washing is primary level of prevention because we do hand washing when there is a risk that we can spread the infection to other people. And they have asked it 2 times in INICET that when you don't use sanitizer, it is not used on visibly soiled hand. Visibly soiled मतलब बाहर से ही दिख रहा है कि हाथ गंदा है. Visibly soiled means you can see it from outside that hand is dirty. And if you can see it outside that hand is dirty, then you have to use soap and water now. Why are you using sanitizer? So we don't use sanitizer here. Okay. And it is the most, and one more question came from there is, what is the most cost effective method of cervical cancer screening? This question has been asked in MCI exam, and all the gynecologists, they answered pap smear. But PAAR textbook of PSM has clearly written that cervical cancer screening best done by pap smear. But if they ask most cost effective method of cervical cancer screening, then answer will be visual inspection under acetic acid, VIA or VILI. That is most cost effective. Cost effective is VIA. Best is cervical cancer screening, best is pap smear. I agree, best is pap smear. But most cost effective is VIA. Okay. So do remember it. Now, all of the following are true about disease except. This is a really twisted question. Let's see you can do it or not. It's a tricky question. First line they are saying incidence of disease is probability. Incidence of disease is probability that a healthy individual will develop the disease during a specified period. Yes, it is correct. Incidence और cumulative incidence का क्या मतलब होता है? Cumulative incidence is same as incidence. It means total new case by total people who can develop the infection, total susceptible population. Okay, susceptible मतलब जिनको infection होने का risk है. Susceptible are those who are at risk of getting infected. So cumulative incidence or incidence means new case by total susceptible. So incidence is new cases, that is correct. Incidence will decrease if new drug is effective in reducing mortality from the disease. See, first do remember this thing. Whenever they talk about drug has almost no effect on incidence. If there is a drug which is effective in reducing death from disease, let's say you found a drug which can prevent diabetes and hypertension people from dying. And I hope you all know this formula on which they ask question again and again, that prevalence is incidence into duration of disease. Duration of disease. So, if you found a new drug which prevent mortality from disease, let's say hypertension death is reduced by your new drug. So, even if your new drug is preventing death due to hypertension, will the new case of hypertension will decrease? New case of BP sugar is occurring in people like me who are not caring about their diet, not doing exercise. So new case is not controlled by drug. Drug only affect prevalence. Incidence remain same. So if they talk about incidence decrease, increase with drug, always the answer will be wrong, because drug, with drug, any drug, incidence remains same. Incidence will not be affected with drug. So no matter which drug they are talking, which case they are saying, incidence always same. So this statement is not correct. True, except they are saying not correct. Now let's try to find out effect on prevalence, because they ask this question and again, that if a new drug, this is very common question, अगर एक नई दवा से डेथ कम हो गई, जैसे ऊपर भी लिखा हुआ है डिक्रीज मॉर्टालिटी, लेकिन बीमारी ठीक नहीं हुई, बट डज नॉट क्योर डिजीज. डेथ तो कम हो गई लेकिन बीमारी ठीक नहीं हुई, डज नॉट क्योर डिजीज. डेथ डिक्रीज बट disease is not cured. Like BP sugar medicine, they prevent the death but does not cure BP sugar. So in that case, what will be the effect on prevalence? अब देखो, क्योंकि लोग मर भी नहीं रहे हैं, ठीक भी नहीं हो रहे हैं, तो वो लंबे समय तक सफर करेंगे. और अगर वो लंबे समय तक कोई भी सफर करता है, ड्यूरेशन बढ़ेगा, तो फॉर्मूला के हिसाब से प्रिवलेंस भी बढ़ जाएगा. What I was saying in Hindi was that because they are not getting cure nor they are dying, so they will suffer for longer time, and if they will suffer for longer duration, prevalence will increase. So if a new drug decrease mortality, does not cure disease, prevalence will increase and incidence will remain same. Incidence remains same, prevalence will increase. And I hope you will remember this concept and this question. But sometimes they change the question and they ask it differently. They ask if drug, new drug, cure disease quickly curing the disease. Let's say you found a drug which can cure BP problem forever. So if drug cure disease quickly, now what will happen on prevalence? See, drug is curing disease quickly. So because it is curing it quickly, duration become less, and if duration become less, prevalence will less. So prevalence will be decrease. But what will be the effect on incidence? As I told you, no matter which drug they are talking about, if they say drug, incidence is almost remains same. So incidence is almost always same, only prevalence is affected. And I hope this example of BP sugar drug will let you understand this concept more better. Okay. So I hope it is clear. Now, this was one controversial question which came in NEET exam, and we have to focus on recent NEET 5-6 question which was difficult, because always and always they copy MCI question in NEET and NEET question in MCI. So they can repeat it. If they ask which has maximum thymine, is it rice, wheat, curd or sabji, vegetable? And a vegetable. Which one has maximum thymine? Don't answer rice. Rice don't have maximum thymine. Maximum thymine out of the 4 is wheat. If rice and wheat is in the option, answer will be rice and wheat. Okay. But wheat has more thymine than rice, almost double. Let's see what PAAR textbook has written here. It's direct page from PAAR recent edition. And you can see in this page that maximum amount is in gingerly seeds. I don't know what is gingerly seed. It has maximum amount. Second maximum is it groundnut, क्योंकि मूंगफली में दाना नहीं, हम तुम्हारे मामा नहीं. In the groundnut, मूंगफली, there is second highest. Third highest is in Bengal gram, chana ki dal. Bengal gram is third highest. So 1, 2, 3. After this third highest, the fourth highest is wheat, gehu. Then there is rice, and you can see rice has half as compared to wheat. That is why Punjabi people और people who are eating wheat, रोटी जो ज्यादा खा रहे हैं वो दारू ज्यादा पचा पाते हैं, क्योंकि रोटी में थाइमिन ज्यादा है, और आपको भी पता है दारू पीने से थाइमिन की कमी होती है. तो चावल खाने वाले दारू कम पचा पाएंगे, दारू पीने वाले ज्यादा क्यों चावल गेहूं खाने वाले दारू क्यों पचा पाएंगे? क्योंकि गेहूं में थाइमिन ज्यादा है. बिकॉज व्हीट हैज मोर थाइमिन, सो पीपल ईटिंग व्हीट like in Punjab and all, they can digest alcohol better because wheat has more thymine as compared to rice. Okay, so you can use this knowledge and you can use this real data from PAAR to answer it more better. Gingerly seeds, then groundnut, then Bengal gram, and then there is wheat, then there is rice. Okay. Second controversial, debatable thing came, 𝐄𝐱𝐩𝐿 criteria. It is based on which thing? It is based on carbon dioxide concentration in the air. 𝐄𝐱𝐩𝐿 criteria simply says that how much ventilation should occur in the air which make the air better. So ventilation should be, they are saying 3000 cubic feet per hour person, and as you can see it is based on carbon dioxide concentration. Okay, 3000 cubic feet ventilation is good, and in an hour there should be 3 to 4 air change. In 1 hour 3 to 4 air change should be there. So this is the criteria of ventilation, 𝐄𝐱𝐩𝐿 criteria, which include what it include? It include carbon dioxide concentration. Now let's talk about two more area space thing. In a school health program, what is the space given to each student? 10 square feet. And in occupational health, factory health, what is the space for each worker? 500 cubic feet. But when they say 500 cubic feet, सारे फैक्ट्री के मालिक इतने चालू वो छत ऊपर ऊपर बनाने लग गए कि 500 क्यूबिक फीट ऊपर का भी आ जाएगा. तो सरकार ने ये क्राइटेरिया रखा कि नहीं, सर के ऊपर केवल 14 फीट काउंट होगा. When they put 500 cubic, what I was saying in Hindi was, when they put 500 cubic feet criteria, the owner of the factory, they started making rooftop very high. So then the government said, no, only 14 feet above their head will be counted. So do remember, school health program, 10 square feet, occupational health, factory worker, 500 cubic feet with 14 feet above their head. Now, let's come to next question. A farmer came with complaint of calf muscle tenderness, headache and conjunctival suffusion. If it is redness in the eye, headache and calf muscle tenderness with fever, it is leptospirosis. But is it icteric leptospirosis or anicteric? If this is the question, icteric or anicteric, what is the answer? Is it icteric or inecteric? So only 5-6 questions are from NEET. I'm not putting all the NEET question, only the controversial question. Leptospirosis is there, but is it icteric or anicteric? Answer is, this is icteric. See, anicteric is mild type, and in anicteric there will be conjunctival effusion, renal manifestation, headache. But in icteric leptospirosis, patient will have calf muscle tenderness also, along with conjunctival suffusion and headache and other thing. देखो, icteric का मतलब आंखों में दिख जाएगा पीलापन, तो icteric है. और अगर आंखों में पीलापन दिख गया तो ये सीरियस टाइप की प्रॉब्लम है. और इस सीरियस टाइप की प्रॉब्लम में ही काफ मसल, आप समझते ही होंगे काफ मसल को, है ना, ये काफ मसल है, इसका टेंडरनेस होगा. तो in the icteric type, which is, you can see the yellowish discoloration in the sclera, there will be more serious problem, icteric, because there is discoloration reached till eye. And therefore, in this only, you will find calf muscle tenderness. So calf muscle tenderness, if they say, you will answer it as icteric. And anicteric will have conjunctival suffusion and headache, but not calf muscle tenderness. And one more thing they can ask is, what is Weil's disease? Weil's disease is combined renal and liver failure. If there is liver, renal, both failure, it is Weil's disease. Okay. Nikhil, bro, इसका चार्जर दे देना यार, आईपैड का चार्जर नहीं है. Thank you, bro. चलो, now, how we make the diagnosis of leptospirosis? We can make it by dark field examination of the patient blood, or we can culture, but culture can take 1 to 6 weeks, so it's difficult. So we can take urine on 10th day to 6 weeks and we can make culture there, and just an extra information. Now, let's come to the main controversial area, and 3 of the good teachers, they answered it wrongly. So let's try to understand this question of diphtheria. In the diphtheria part, yes, it is charging. Thank you, Nikhil. Love you. Chalo. So the question was, there is a 5-year-old boy with diphtheria. He came to clinic. What should be done for his 2-year-old brother who is fully vaccinated? What should we do with that? So let's talk about the treatment directly from PAAR textbook. PAAR says it that if someone is received immunization within 5 years, no further action is needed. If someone is immunized more than 5 years, in more than 5 years, we give booster dose of toxoid. But if someone is bhoola, forgotten the history, or non-immunized, then we give, of course, one diphtheria toxoid with erythromycin. So what I was trying to tell you, in the contact thing, I am telling you simple thing. I hope you will remember it. This is very simple to find it out, the correct answer. If they are saying that the child is 5-year-old, this is the case. This is not the one who came to hospital. Hospital आया था इसका 2 साल का छोटा भाई. This 5-year-old boy, this is the case. He have not came to hospital. Who came to hospital? This 2-year who is living with the 5-year. And this 2-year is fully vaccinated. If 2-year is fully vaccinated, it means in last 5 years he received diphtheria. अगर 2 साल को टीका लगा है मतलब 5 साल के अंदर लगा है. If he is fully vaccinated, he is taken it in 5 years. And if someone is vaccinated in last 5 years, then we do nothing, we only reassure. So reassurance, when do we do? If contact last vaccination in 5 years. If last vaccination in 5 years, we only do assurance, nothing is needed. It is written in PAAR. We give only antitoxoid if last diphtheria, if last vaccination of diphtheria more than 5 years. More than 5 years, only antitoxoid. Only penicillin we never give. We never give only penicillin. But if someone is in the last criteria, if someone, when do we give the antibiotic? Antibiotic can be penicillin or erythromycin. Because penicillin can cause anaphylactic reaction, so mostly we are giving erythromycin. So erythromycin plus toxoid, this we give if someone is unvaccinated, not vaccinated, or forgotten the history. So if someone is not vaccinated, we mix antibiotic plus toxoid. Less than 5 years, nothing. More than 5 years, toxoid. Is this clear? Less than 5 years, nothing. More than 5 years, toxoid. And this is the same as tetanus. In tetanus also, if someone has taken last tetanus in 5 years, we do nothing. 5 to 10 years, we give only toxoid. So above two things is same. And if someone is not vaccinated, then we add penicillin. So this is about contact. Now, they can ask about case. What will you do with that 5-year-old boy? How do we treat? So in the treatment, PAAR has written that if it mild early pharyngeal laryngeal disease, we give 20,000 to 40,000. If it is moderate nasopharyngeal, we give 40 to 60. And if it is severe, 80 to 1 lakh. So tell me one thing. This question has also come. Which one is more infective, nasopharyngeal or oropharyngeal? In nasopharyngeal, if you sneeze, hachi, you can spread the fomite nasal droplet in very large area. So nasopharyngeal is more infective than oropharyngeal. So oropharyngeal 20-40, nasopharyngeal 40-60, serious 81 lakh. There is nothing 60-80. And serious directly 81 lakh. But whenever we give antitoxin, we always treat with penicillin or erythromycin for 5 to 6 days. So we never give penicillin alone or erythromycin alone. We always mix penicillin, erythromycin with toxoid. So do remember it. If the patient is coming with mild, we give 20,000 to 40,000 toxoid. If it is moderate, 40 to 60,000 for nasopharyngeal. And if it is severe, we give 80 to 1 lakh of toxoid. And in the severe, 80 to 1 lakh toxoid, plus we also add antibiotic. This antibiotic can be erythromycin or azithromycin. But if they ask what is the drug of choice for diphtheria, you can see in every diphtheria case, we are always, in every case, we give antibiotic. It's not that antibiotic is only given in severe case. Antibiotic is always given, but toxoid differ. So drug of choice is definitely diphtheria toxoid. Diphtheria toxoid is drug of choice. But if they ask antibiotic of choice, Then antibiotic of choice is erythromycin in adult and azithromycin in children. And the good thing here is that this is the same thing for pertussis. So do remember this question, because in NEET 2023 they have asked it. What is the drug of choice for diphtheria in children? That is azithromycin. Diphtheria in adult, what is the antibiotic of choice? If they ask, not drug of choice, antibiotic. Drug of choice, answer is toxoid. Antibiotic of choice in adult is erythromycin. And this is the same for pertussis. So pertussis and diphtheria, they both have, in adult we give erythromycin, in children we give azithromycin. But do remember, for diphtheria, the drug of choice is toxoid, diphtheria toxoid. But in all the case, along with toxoid, we always give, in addition to antitoxin, every case should be given penicillin or erythromycin. So it's for every case, not only for severe case. One more question which has come from here is, we give more dose to children of toxoid or more dose to adult. So if you see it here, they have written that for immunizing children, we are using 2 loefflers of diphtheria toxoid. But when it comes to adult, for immunizing adult, for immunizing children over 12 years, adult we are giving 2 loefflers. But in children, we are giving 25 loefflers unit. So this is controversial. Usually we give less dose in children, more dose in adult. But here, adult get less toxoid. उल्टा हो रहा है. यहाँ बड़ों को कम मिल रहा है, बच्चों को ज्यादा मिल रहा है. Children getting 25 loefflers unit, and adult or more than 12 years, they are getting only 2 loefflers unit. So here, more dose is in children, less dose is in adult. Okay. So this is again one question which has been asked. This is the complete coverage of diphtheria, and I am very sure one question on diphtheria toxoid treatment or vaccination will come in this exam. So do remember this diphtheria topic well. Now let's go to this last one. New question came on this topic. What is longevity dividend? See, whenever they use the word dividend, dividend means bonus. Bonus. And when we are talking about bonus, it's a good news. So when it is good news, more aging lead to more disease, that's a bad news. More disease is a bad news. Intervention will cause delay in related disease while aging. Yes. This is longevity dividend. सरकार की ओर से ऐसा कुछ किया जाए जिससे लोग बुढ़ापे में बीमार कम पड़े, और जब वो बुढ़ापे में बीमार कम पड़ेंगे तो देश के लिए कमा पाएंगे, और देश के लिए कमा के वो देश को एक बोनस देंगे, देश की उन्नति में अपना हाथ बटाएंगे. What I was saying in Hindi was longevity dividend means we make old age people fall less ill by making them good health facility, doing some intervention. So if it will decrease the disease in old age, they will be able to earn more, and therefore they will help the country in the economical development also. So it will like a bonus to the country. So longevity dividend means giving them less disease in old age so that they can be productive for the country. So intervention will cause delay in related disease while aging. This is longevity dividend, and this is what being written in various online text also, that longevity dividend is simply gain that can be realized if increasing in life expectancy is matched by health improvement. Like in India, future Indians are going to be very old age, because after 20 years we have more old age people, going to have more old age people. So we need to make health improvement in old age so that they can be good for economically productive for the country. Now one question which come on this topic is of quali. If they say government is doing intervention to improve life expectancy, government intervention, in any question, if you find the word intervention to improve life expectancy they are improving, and they are also improving quality of life. So quality of life added due to intervention is quali. Therefore, when they say government intervention to improve life expectancy, answer can also be quali. And quali means some intervention, whether it's dialysis center, or suppose, let's say in your group, suppose there is Vijay Kumawat, who is, let's say, from Delhi. And he found in Delhi, old age people are having only one problem. Whatever you tell to them, they answer by one word. And they are having hearing discomfort. So Vijay Kumawat, he went to Arvind Kejriwal and said, 𝐿𝐾𝐻𝐸, give me some funds so that we can distribute hearing aid to old age people. So by giving hearing aid, doing this intervention, you improve quality of life of old age people. And whenever we improve quality of life by intervention, this is quali. Okay. But when we improve their old age, then this is longevity dividend. Okay. So Vijay Kumawat is improving quality of life of Delhi people. That is example of quali. Now Vijay Kumawat also have a question: how much funds should we spend on healthcare? 2.5% or 5% of GDP? PAAR textbook has written it that according to WHO, 5% GDP should be on health. This is what being written in PAAR. I was not aware of this information earlier, but one day I was reading the PAAR again and I found this line that 5% GDP should be on health according to WHO. How much Indian government is giving on health? Indian government is only giving around 1.05% GDP on health for last 34 years. Indian government is giving 1.05 GDP on health. So this question has been asked in INICET exam that if you want to represent causes of health system failure, which diagram will you use? So there is a diagram which is known as fishbone diagram, and fishbone is also known as Ishikawa diagram. So in this fishbone or Ishikawa, we draw this fish. You can see this is the central bone of the fish, and then this is the fish head area. And then these are the bones. So we are writing with the fishbone or Ishikawa diagram, you can represent that why our health system is in poor condition. First reason I said is less GDP, 1.05, when the expectation is 5%. Second reason is that we have only half PHC, half CHC, 1/3 subcenter. All over the guideline which we read is the dream. We have not achieved it. So less hospital. Third reason can be we are only giving contractual job, not permanent job. So many doctors are not going to join. Second reason can be less salary. And then there is other issues like less safety precautions and less good working condition. So these are making our doctor less, and this is causing health system poverty. So it is represented by which diagram? Fishbone or Ishikawa. So fishbone or Ishikawa is also qualitative data representation method, because health system is just about quality. You cannot measure health system and say that our health system is 2.8 good. We can say health system is good, bad, poor category, and because it is in category, it is qualitative data. So which diagram represent the qualitative health system failure? Ishikawa or fishbone? Okay. Now one more question I want to discuss, which is very controversial, is which of the following is indication for bedaquiline regime? Although it is pharma question, but PAAR textbook has written it clearly that there are 4 indications for bedaquiline. 4 indications are there. Let's read those 4 indications. First indication is when you are MDR with fluoroquinolone or second line injectable. So see, when we talk about XDR definition, XDR means resistance to isoniazid and rifampicin, at least 2 resistance, plus second line injectable or fluoroquinolone resistance. This is the definition of XDR. And this is what statement 1 is saying. MDR with second line or fluoroquinolone. This is first line saying. But what is what is the real definition of XDR? The real definition is second line plus first line fluoroquinolone. When all 3 are there, this is XDR. And line 1 is writing MDR plus second line or fluoroquinolone, any one. So MDR plus second line or fluoroquinolone, or MDR plus second line injectable plus fluoroquinolone resistance, all 3. So either 2 or 3, we give bedaquiline. Third is when it is mixed pattern XDR. Mixed pattern resistance means XDR, that means all the 3 plus first line, second line resistance, plus first and second line resistance. Okay. And last is MDR plus XDR. So if it is MDR, XDR both, then we give it. XDR plus first second line, then we give. MDR plus either SLI or fluoroquinolone, then we give. Or MDR plus SLI plus fluoroquinolone, then we give. So these are the 4 indications, which is clearly written in PAAR. So these are the 4 indications. Therefore, the better answer will be answer option D. Rifampicin resistance is we count in MDR TB with any one fluoroquinolone resistance TB or any one second line. This is a better answer. We do give bedaquiline in MDR. I'm not saying C is wrong. C can also be correct because C is writing rifampicin with both CAT-G in HE. And CAT-G in HE mutation occur in isoniazid resistance. So option C is just writing MDR. In MDR, we do give bedaquiline, but it is not written as an indication in PAAR. MDR alone is not written as an indication. Written is MDR plus SLI FQ, which is option 4. So that's why option 4 is better. When we write rifampicin with any one fluoroquinolone or SLI, then that is one of the indication. And I hope you all know in the recent MDR TB guideline, government is now giving BPAAM regime. Have it written there? No. What is BPAAM regime? Let's write it here. In the BPAAM regime for MDR TB, this is a very likely question this time. Government said we will give only 4 drugs. B for bedaquiline, P for pretomanid, L for linezolid, not levofloxacin, and M for moxifloxacin. So these 4 drugs are now being allowed for MDR TB. Remember, MDR means at least rifampicin plus isoniazid, both resistance should be there minimum. Then only we kill bedaquiline. And how does bedaquiline work? They can ask. Bedaquiline work by ATP synthetase inhibitor. See, it target ATP synthetase. So bedaquiline is mainly working as ATP synthetase inhibitor, and we can give it to people more than 18 years, but we cannot give it in pregnancy. Pregnancy is a contraindication. Okay. So this is one more question. One more controversial question of recent NEET was that G5P4 lady came with report on ultrasound as per PSC, and this lady with 4 female, they had said 30-year age. 30 year of age, and this was question number 35, not 35 age. And what is correct to do? Will you do USG, don't see fetus gender, don't tell the woman? Or will you do USG, see fetus gender and don't tell woman? Because we can never tell the mother and we cannot deny ultrasound. So these 2 is gone. What will you do? Will you know the gender and don't tell mother, or will you don't know the gender and don't tell mother? क्या आप gender का पता लगाएंगे या नहीं लगाएंगे? तो correct answer है कि हम gender का पता नहीं लगाएंगे. We do not see the fetus gender. And of course, we don't tell the mother. There are 5 conditions in which we can see the fetus gender. What are the 5 conditions? Age more than 35 years. First condition is age more than 35. Second condition is when there is previous history of spontaneous abortion. Third is when there is history that mother has gone through X-ray or some teratogenic drug exposure. Fourth is if there is history of mental problem or congenital anomaly in the family. And fifth is when the board allow. So 5 condition देखो क्या क्या है. 35 साल से ऊपर वाली फीमेल के बच्चे का जेंडर पता लगा सकते हो. अगर माँ के 2 से ज्यादा एबॉर्शन हो चुके हों, या माँ के परिवार में किसी को मंदबुद्धि या कॉन्जेनाइटल एनोमली हो तब लगा सकते हो, या तो माँ ने एक्सरे या कोई ड्रग ऐसा लिया हो जिससे बच्चे को खतरा हो तब पता लगा सकते हो, और फाइनली मेडिकल बोर्ड के अप्रूवल से पता लगा सकते हो. सो दीज आर द 5 कंडीशन. लेस देन 35 ईयर, हिस्ट्री ऑफ एक्सरे और टेराटोनिक ड्रग एक्सपोजर, 2 or more abortions, history of congenital anomaly in the family, or medical board approval. One more question came, who consists the medical board? So whether it's MTP Act or whether it's this PCPNDT Act, medical board always has 4 people. First is definitely obstetrician, who is going to think about mother. Second is the pediatrician, who will think about the child. Third is the radiologist, who will make the decision. And fourth is the board member, which is can be member of any social organization and other thing, who will be independent of making the decision. So there are 4 people in the medical board. Okay, I hope you will remember it. Now let's come to the next question, and there is one controversial area of question which I want to discuss. MTP Act. I hope you all know, in the MTP Act, Medical Termination of Pregnancy Act, again the board will be same, and up to 20 week it's all normal, and we can do abortion of any condition, but 20 to 24 week, if this abortion is going to happen, we need 2 doctor permission. Here 1 doctor is good enough. Here 2 doctor permission is needed, 2 RMP registered medical. And in the 20 to 24 week, only 3 condition can we do the abortion. One is the rape, one is the incest. Incest means family member did sex and pregnancy happened. That is incest. And other is when there is congenital anomaly. For failure of contraception, only up to 20 week we do MTP for failure of contraceptive. Failure of contraceptive, if there is failure of contraceptive, then by 20 week, you will be able to see the growth in the abdomen and you can report it by 20 week. After 20 week, we don't terminate for failure of contraceptive. Only 3 conditions we terminate 20 to 24 week. And then they can ask, who do we terminate after 24 week? After 24 week, we need permission of medical board permission is needed. And after 24 week, only 1 condition, congenital anomaly only. In rape also, we don't allow after 24 week. Why? Because if there is rape which lead to pregnancy, the swelling can be seen up to 20 week, 24 week maximum. It's not that swelling of abdomen will remain hidden till 24 week. But congenital anomaly, like sometime like when you are finding tracheoesophageal fistula and all, sometime even till 24 we are not able to find it. So congenital anomaly is allowed after 24 week with medical board permission, but only 3 are allowed 20-24, and failure of contraceptive only till 20 week. Okay, I myself was confused in the beginning and I used to think failure of contraceptive can go between 20 to 24. But then when I discuss it with one of the lawyer and one student also discussed it with me properly, failure of contraceptive is only till 20 week, not after 20 week. Okay, do remember this part. These are very important areas. Again and again they are asking, they will ask it again. Next, this is a very controversial question which some people, even I gave it wrong on the first time. The question was that a statistician want to study the effect of medicine in 3 groups, human, animal, plant. And he selected randomly out of these 3 groups which sampling is performed. Is it clusters random sampling? Is it stratified sampling? Is it simple random sampling? Is it systematic sampling? So, first thing is simple random means we are just using lottery method. By software or lottery method, we are choosing any 10 out of 100. That is simple random. And simple random is done for homogeneous population. Best for homogeneous. Homogeneous means if we have to only do it on animal or human, we choose human only. Human are all equal. So then best answer will be simple random because it is for homogeneous. Systematic sampling means if we are choosing every second person, every third person, like if you want to know whether villager are using condom or not, what do you think? Villager use condom or not? How can you know? You have not checked what is below their lungi. So you don't know whether villager use condom or not, and you did every second and fourth house interview to know whether they use condom or not. So if you are doing second, fourth house interview, you are following a system, nth number you are choosing. That is systematic random sampling. And simple stratified means you researcher divide population and then choose equally from two group, then choose equally from different group. This is stratified or stratified random sampling. Stratified random sampling. And do remember, stratified random sampling is best for heterogeneous population. Because it is best for heterogeneous population, me and many other people, they thought initially that correct answer will be stratified because it is best for heterogeneous. But stratified is the answer when we are dividing them into three groups. Here, human, animal and plant are already divided naturally. And if they are naturally divided, then the better answer will be cluster random sampling. Cluster random sampling means we are choosing cluster of people or objects randomly from those groups which are naturally divided. For example, if you want to know which one has less vaccination, Bihar or Uganda, what is your answer? Which one has less vaccination? And don't look at me and say Uganda, and don't tell me as Uganda, okay? So if you want to know Bihar or Uganda, which one has less vaccination, the WHO protocol says that we will choose 7 children of 12 month to 23 month from 30 village. 7 children from 30 village we will choose. So these children are already living differently in different village. We are not dividing them into village. Village is their natural division. And we are choosing 7 people from 30 villages. So total sample size is 210. We will go to their mother and we will ask how many children are vaccinated, and we will do the WHO immunization study by cluster random sampling. So cluster random is when they are naturally divided. Stratified is when you divide them. And here we are not dividing them. They are naturally divided in the three groups. So better answer will be cluster random. Let me explain it with an example. Suppose I want to choose 10 students from the class for a party. Suppose is the main word. So I can use all the students who are replying me, their name I will collect, and I will choose by lottery method any 10. This is simple random. But suppose in that party I want that I am a happily married type of man, but there should be more affair between boys and girls. So I said, rather than choosing simply, if I choose simply 7 boy can come out of 10, or 9 girl can come out of 10, but I want there should be 5 boy, 5 girls, so that in the party they can also do some gup-chup, and they can also have some love among them. So I divide you, all the students who are replying to me, in boy and girl, and then I choose 5 from boy, 5 from girl. That is a stratified random, because I divided and then choose. And if I choose every 7th student, every 7th is systematic random because I am following system. But let's say I choose 4 people who had done their MBBS from Kyrgyzstan, 4 people from those group who have done their MBBS from Philippines, 4 from those who have done it from Russia. So this time you are already doing it in different country. I am not creating the difference. I am just choosing 4 people from different cluster. So if I am not dividing you, you are already divided based on some origin. Your origin is different from which you come here. That is cluster random. But when I divide you in boys and girls and then choose, that is stratified. Like for example, in exam, they can also give you this question that people differ, diet differ based on religion. Okay. And then you are doing a study to know effect of religion on diet. Study to know it. Have which sampling? Which type of sampling? So what is happening here? People are all same, but you are dividing them into different religion and then choosing equally from different religion to know the thing. So if you are dividing them into different religion and then choosing, better answer will be stratified random. Stratified random sampling. Let me give you one more example. In my study on organ donation, my guide asked me to choose 1050 people by simple random sampling from 48 villages. So I did simple random because all of the people were just villager. But in my study, one question was, does religion promote organ donation or not? So I should not have done simple random. In the beginning, I should have decided that I will choose 333 people from Sikh religion, 333 from Hindu, 333 from Muslim, and divide them and then choose equal people to get the answer whether religion promote organ donation or not. So if I divide them into religion and choose a stratified random, but let's say if I choose 2 people from every 48 village, that is cluster random because they are already living in villages separately and I'm choosing 2, 2, 2 from each cluster. So cluster random is the answer here because human, animal and plant are 3 groups different from their origin and we are choosing randomly out of these 3 groups. So they are already divided. That's why the better answer is cluster random sampling. Okay, chalo. The last thing is which is very controversial and which we very rarely read is about Sanchol vaccine. So there are 3 vaccines for cholera which I also don't teach in classes, but in NEET they have asked this time. So in the 3 vaccine, one is Dukoral. Surprise is in the Dukoral there is only one V. cholerae strain. So Dukoral do not have 2 strain. Dukoral have V. cholerae and it has recombinant cholera toxin B subunit. So Dukoral has B subunit and V. cholerae 01 strain. So which strain? Only one strain. So Dukoral is which type of vaccine? Monovalent or bivalent? Dukoral is monovalent because it has only one V. cholerae 01 strain. That is Dukoral. Okay. Now, what is Sanchol and UV-chol? Sancol or UV-chol, they both are bivalent. It is written. You can see they are bivalent because they are not only for 01 strain of cholera bacilli but also for 0139. So, and UV-chol is written is same as Sanchol. So it's one thing which they have asked, and I hope if they repeat it, they will repeat it like that. Sanchol they are asking. So Sanchol we all know is which thing, monovalent or bivalent? Bivalent. Monovalent if they ask, monovalent is only one thing, Dukoral. I'm sure many of you have not read this part. So I keep it here intentionally to revise it. Bivalent is either Sanchol or UV-chol. So now let's read about Sanchol, UV-chol one more time. Sanchol they are saying vaccine should be administered orally in 2 liquid doses, 14 days apart. 14 दिन के अंतर पे 2 बार देंगे और सेम तरीके से संचोल देंगे, यूवी-चोल देंगे. तो यूवी-चोल और संचोल we give 2 doses at a gap of 14 days. Now let's talk about Dukoral. Dukoral say we gave one booster dose, okay, after 2 years of adult. So we give 1 dose and then 1 booster dose. According to manufacturer, we give 2 oral dose first, and after giving 2 oral dose, we also give 1 booster dose. Okay, so we are giving 2 dose and then 1 booster dose. So that means in nowhere we are giving 1 dose. 1 dose option is always wrong for cholera vaccine. Cholera vaccine is always given in 2 doses. Dukoral is monovalent and Sanchol or UV-chol. Sanchol or UV-chol, they both are given 2 doses and they both are bivalent. So Sanchol, UV-chol bivalent 2 doses and Dukoral monovalent. What is correct for Dukoral? Monovalent 1 dose or 2 dose? Correct answer is monovalent and 2 dose. So Dukoral monovalent 2 dose, Sanchol, UV-chol bivalent 2 dose. I hope you will remember it. Now, Bharat Dwivedi is saying, good evening sir, बहुत डर लग रहा है, please कुछ करिए. So Bharat Dwivedi bro, fear is a good thing, and if fear is coming, it means you have studied well, because only those who have studied well, they will be feared. जो पढ़ेंगे वही तो डरेंगे. अगर पढ़े ही नहीं हो तो फिर डरोगे भी नहीं. क्या जरूरत है डरने का? जब पढ़ा नहीं है तो नहीं डरेंगे. और this fear is normal in this exam time. First thing is, don't give too much importance to fear. some fear keep you alert. Some fear keep you alert in exam time also. So some anxiety, some fear is good. The problem is when anxiety and fear override you. And to avoid that overriding, one of my suggestion is that in this last 5 days which you are left, in this last 5 days, every day, sit in this time 9 to 11:30 and do 150 question. If you did it before 11, it's okay. If you did it till 11:30, it's okay. Then take a break of half an hour, have your meal and all, and read some of the explanation of the wrong question which you did wrong. Read their explanation. Then 2 to 4:30 sit again, second sitting, and do 150 question again. Last 5 days, 300 question per day should be solved. Now you will say that, sir, in last 5 days I have thought I will revise 4 subject, 5 subject, and here you are asking us to do question. So first of all, suno sabki, karo apne man ki, listen to everyone, but do whatever your heart is saying. So my advice is just advice. It's not rule. And if you have planned something, do it. Why I am advising you to do this 300 question per day? Because if you do 300 question per day in exam, anxiety and fear will not affect you, because you are in a flow to do 300 question every day. So you will do it easily in the exam day also. Second reason why I tell you to do this is, if you have a routine of 300 question per day in this 9 to 11:30 and 2 to 4:30, then due to that routine, in your last 5 days, many people, due to their nervousness and all, they stop studying and they only watch YouTube videos whichever come. Watching YouTube video is not that much fruitful as revising PYQ, because all the people, including me, what are we teaching? We are just teaching previous year question actually. So if you do it yourself, that's much better. So my advice to all of you is, in last 5 days, practice 300 question per day, so that you will be in the flow and your exam will rock. जो लोग घर पे ही 300 कभी नहीं बनाए हैं, वो ये ऐसा कैसे सोच सकते हैं कि एग्जाम में मैं 300 बना डालूंगा? एग्जाम में फिर वही 50-100 होते होते साएं हवा चलने लगती है। सेकंड सेशन में फिर क्वेश्चंस में इंटरेस्ट नहीं आता है, कंसंट्रेशन नहीं आता है, फियर एंजाइटी आती है, क्योंकि आपने घर पे प्रैक्टिस नहीं किया है 300. So this is one advice: do 300 question per day. Second advice is, in this last 5 days, do year-wise PYQ, not module-wise PYQ. If you are taking 2021 NEET paper, take 2021 NEET, first do anatomy. After doing anatomy, come out from the app, do physio. After doing physio, come out again, do biochem, then do PSM, and like that, do all 2021 year-wise. Because if you do year-wise, you can know which topic are getting repeated. And year-wise give you a feeling also that yes, I have completed this many year of question. So in this last 5 days, you have to revise 6 year of NEET and FMG question by solving 300 question per day. Some of the question which you have already revised, FMG, some 3-4 year question you have done and revised. So this is part you have done. I want you to go till NEET also and do that also, because NEET question are copied word to word in FMG exam. FMG recall is never accurate, because after first session no one try to recall, after second section everyone go for party, and after party who can recall? So FMG exam recall is not good. NEET exam recall is real word to word. So if you will do NEET PYQ, you will be able to know what is the exact language in which they are asking the question. So in this last 5 days, do 300 question per day by year-wise PYQ, and do focus on 6 year of NEET and 6 year of FMG. But main thing is 6 year of NEET you must do. If you will do 6 year of NEET, right now if you are getting 140 marks or 150 marks or 130 marks in your mock test and all, I can guarantee you in 5 days, if you do 5 day 300 question and did NEET 5 year, your marks will jump by 30 marks in just last 5 days. Your marks can jump by 30 marks. So this power of last 5 days is not less. In 5 days, if you are getting 180, you will be more than 200. If you are getting 130, you will get 160. So if you do every day 9 to 11:30 practice, you will be confident, your PYQ will be done, and you will be in flow. So exam anxiety, nervousness, fear will not affect you, and your routine will be solid. You will be in habit to wake up and give exam from 9. So your sleep cycle will also be good. Okay. Plus, main reason why we should do PYQ, because 95% question come from the same topic which has been asked early. Don't go for update. Many coaching and many teacher will bombard you with update, but update is hardly one question out of 300. But 95% are previous year topics and that. So if you focus on previous year, that is more rewarding. Update is never rewarding. Update is a tactics by coachings to get your attention, because they know you are foolish enough. Update, you think. But main focus should be previous year question. Okay, and do it in previous year, because if I am an examiner, I have to create question. I am burdened with my own life and all. I will not create new question. I will probably take some question which is already being asked, change the language, ask it again. Or I will go to the computer which has a store of some previous question, and I will take some question from there. So that's why, and mostly pediatrician or clinician, they see such common disease. That's why they have asked the question in the past from those disease. So whatever is the common disease, those disease question will also come again and again. So please मेरे दोस्तों, आखिरी 5 दिन रोज एग्जाम के टाइम में बैठ के 150-2 सेटिंग में क्वेश्चन बनाओ. 300 क्वेश्चन आप डेली बनाओगे प्रीवियस ईयर क्वेश्चन नीट के, तो आपके मार्क्स भी बढ़ जाएंगे, कॉन्फिडेंट भी फील करोगे, और एग्जाम में एंजाइटी नर्वसनेस भी नहीं होगा, और आप फ्लो में आके एग्जाम को रॉक कर दोगे. ओके, बाकी सुनो सबकी, करो अपने मन की, तो जो सही लगे वो करो, बट दिस इज माय एडवाइस व्हिच विल हेल्प यू अ लॉट. ओके, थैंक यू सो मच, एंड डू रिमेंबर one very good way to concentrate is after a fixed timing, let's say 9 p.m, switch off your phone. Have your phone till 9, but if you use your phone in night, you will not sleep till 2, 3, 4 a.m. And if you are watching something all of the time, your retina is getting excited, the sleep will be problem. So if you will switch off at 9, you will be able to sleep better and your routine will be improved. But remember one more thing, in the exam night, if you are unable to sleep due to some reason, it's not a big deal. And our psychiatrist friend Ankur Jain sir, he had 1 or 2 toppers of NEET who called him and said, sir, I was unable to sleep. In spite of that, I got 2nd rank in NEET exam. How? If you are unable to sleep, it's not a problem, because you have read things many times, your mind will recall. If you are unable to sleep, my suggestion is take paracetamol tablet, plus take some gas 𝐿 tablet, 𝐿 20 mg. If you will take these 2 tablets, paracetamol will remove fatigue and all, 𝐿 will remove gastric problem, and then take breakfast for sure. Don't ignore importance of breakfast. Good breakfast will keep your mind relaxed and calm. So don't go to exam without breakfast. Unable to sleep, don't worry. Now, why I am preparing you to ready for this situation? Because स्लीप एक्स बंदी की तरह है, एक्स बंदे की तरह है, जितना भाव दोगे उतना दूर भागेगी, नहीं आएगी. तो तुम स्लीप को भाव देना ही बंद करो. आई तो आई, नहीं आई तो कोई बात नहीं, मैं फिर भी एग्जाम फोड़ दूंगा, और देखो नींद आ जाएगी. What I was saying in Hindi was, sleep is like your ex. The more importance you give, the more they will run away. So ignore बहुत धड़ाधड़ मैसेज आए, या तो फिर बच्चे बहुत ज्यादा थे। अंकुर सर के बाद तक तो लोग सुन रहे थे। हेलो वीडियो लोग, so sorry for this sound thing. I hope that the exam part discussion which I was doing, ki in the morning take breakfast, and if you are not feeling good, take PCM and Omage tablet. And PCM Omage will make your stomach feel good. Breakfast will keep you calm and you can rock. Now let's come to this question, which is not a criteria of SAM. So in the SAM, there are three criteria which they ask again and again in PDA, PSM both. First criteria is that, I am repeating this question whole, don't worry. In the SAM, and thank you, you are giving so much attention to every question, very good. And this is very common area of question, SAM, hai na? I was doing this T&D in NLC, so that logo was there. So in the SAM, three things is there. First is low weight for height. हाइट बढ़ गई है यानी क्रॉनिक प्रॉब्लम नहीं है, क्योंकि अगर किसी को बचपन से दिक्कत होती है तो हाइट नहीं बढ़ती है। जैसे लो हाइट फॉर एज लिखा है ना, लो हाइट नहीं बढ़ी यानी क्रॉनिक प्रॉब्लम है। लेकिन लो वेट फॉर हाइट का मतलब होता है कि हाइट बढ़ गई, वजन नहीं बढ़ रहा है, बंदा सूख गया है, बंदी सूख गई है। तो जो सूख गया है उसको कहते हैं वेस्टिंग, और यह है एक्यूट मालन्यूट्रिशन। One thing which you always have to remember is, this is what I was saying in Hindi earlier, if the height is low, problem is chronic. But if height is good, weight is not good, low weight for height, this is acute problem, this is wasting. And SAM should have low weight for height less than -3. Second thing, that there should be pedal edema or visible wasting, and pedal edema for Kawasaki-Yorker, visible wasting for marasmus. And third is mid-arm circumference less than 11.5 centimeter. This will be red color. This we call as SAM. So do remember, SAM has A, B, D and criteria. Low height for age is chronic. This is area which question asked again and again. So I hope it is correct. Yes. Wasting edema and low weight for height. Less than 3 standard deviation and MAC less than 11.5. Okay, chalo. Now let's come here. Which of the following is not a live vaccine? So we have to remember the classification of live and killed vaccine. And sometimes they create a clinical question also. They will create a clinical question that, let's say there is a child who is having nephrotic syndrome and taking a steroid. Which vaccine cannot be given? So I hope you all know live vaccine is something which is contraindicated in immunocompromised people. It is also contraindicated in pregnancy. But in pregnancy, all live vaccine are contraindicated except yellow fever vaccine. Yellow fever can be given even in pregnancy. And if you give yellow fever vaccine once, it will protect lifelong. So yellow fever give lifelong protection. Now, which one is not a live vaccine, they are asking. So for answering such question, we have to remember all the live vaccine. Then we can answer which one is not a live vaccine. And there are total 11 live vaccine. What are those 11 live vaccine? I have not written here. So let's revise what are not live vaccine and what are live vaccine. Live vaccine is very simple to remember. 5 can be remembered by the mnemonic CP-PAAR. Come to CP, and a center point in Aligarh and cannot place in Delhi. If someone is saying CP-PAAR, means it is an invitation for date. Gupchup, gupchup. So what is C stand for? Cholera. P stand for plague. P also stand for polio. I stand for influenza. And J for Japanese encephalitis. Why I made these 5 together, CP-PAAR? Because these 5 are both live and killed. So they can be used as live, they can be used as killed. Mainly you have to remember the remaining 6 vaccine. And in the 6, you already know one thing, yellow. Because yellow fever is live, but it still can be given in pregnancy. Then all the vaccine which are given by oral route is always live. Like rotavirus is live, oral polio is also live, And typho-oral is also live. And typho-oral is given on day 1, 3, 5. Today, then 1 day gap, then again 1 day gap. So rotavirus, typho-oral or oral, yellow is all oral are live, so they are live. Yellow is live. Plus MR, measles, rubella, and BCG. I hope you all know these two are live vaccine. So 5 is done. Last you have to remember is varicella, because in varicella the strain is Oka. You all must have seen that performance. Savila vila, savila vila. It's time to Africa, waka waka, ayo, hai na? Who gave it? Sakira, right? Which type of performance was it? It was a live performance, na? So varicella Oka strain is live. One thing you have to remember. Remaining you already know, and you can remember all 11 live vaccine together. So these are live vaccine which we cannot give. So which one is not a live vaccine? Hepatitis B is not a live vaccine. Varicella, measles, rotavirus, all are live vaccine. So in an immunocompromised or pregnant female, we can give hepatitis B. We can also give rabies in pregnancy. Don't think rabies immunoglobulin or vaccine is not given in pregnancy. We can give it, but we cannot give live vaccine except yellow fever in pregnancy. So this is live. And if sometime they ask about killed vaccine, see, so easy to remember. If they ask killed vaccine, you just have to remember 2. Total killed vaccine are 7, but you need not remember all 7, because 5 are CP, IJO. 5 is done. Only 2 you have to remember, rabies and hepatitis A, and you're done with killed also. Rabies, hepatitis A. If they ask protein vaccine, very simple, P for protein, P for pertussis. So pertussis is protein subunit vaccine. Protein subunit is pertussis. Rabies is killed. So simple. Okay. Live is already we remember. And then hepatitis B is a recombinant vaccine. It's a recombinant vaccine. And they have asked that in the recombinant vaccine hepatitis B, which subunit is used? Option is HBC, HBE, HBS. So you have to remember HBS. S subunit is used, surface subunit is used, because घुसा है जैसे हेपेटाइटिस बी, उसके सरफेस के खिलाफ ही सिपाही होंगे तो तुरंत इंफेक्शन दूर भाग जाएगा ना, इसलिए सरफेस के खिलाफ ही एंटीबॉडी बनाना है तो सरफेस एंटीजन यूज करते हैं. What I was saying in Hindi is when the hepatitis B virus enter, if the antibody are against the surface protein, then it will not be able to infect us. So we will be get rid of that. So the component is a hepatitis, which are HBsAg plus DNA. Surface antigen and DNA is there. So we know the classification now, and I hope you can answer this. There was one question which came on the basis of growth chart and weight for height and all this concept. First thing is they can ask it, and they have asked it, that which type of growth chart is there in Anganwadi. So in Anganwadi, we draw the growth chart which is weight for age. Weight for age we draw. Why? क्योंकि अगर किसी बच्चे का वजन कम है तो वजन कम होने का रीजन क्रॉनिक भी हो सकता है, एक्यूट भी. किसी बच्चे का अगर वजन कम है तो हो सकता है उसको बचपन से खाना ना मिला हो, या हो सकता है 1 महीने से लूज मोशन हो रहा हो, या दोनों बात हो. इसलिए लो फॉर वेट, व्हाट आई एम सेइंग इज वेट फॉर एज इंडिकेट बोथ acute and or chronic. And or chronic means any one of it can be reason for the malnutrition. If the child weight is less, it may be less due to chronic diarrhea, or it may be less due to diarrhea from last 1 month, or it may be he is having chronic malnutrition plus diarrhea. So that's why it is and or. They can be separate or together. So in Anganwadi, weight for age is drawn. And up to which age children come to Anganwadi? Children come up to 6 years in Anganwadi. So Anganwadi weight for age drawn and up to 6 years to remember. Now in the growth chart they have asked that what do we call the line between second and third? What do we call this part which I am drawing from green? So second and third line in between there is no mild malnutrition, it is moderate malnutrition. There is nothing like mild malnutrition. Normal is between 50 percentile of boy weight, third percentile of weight of girl. Then moderate is between second and third line, and if someone is less than -3, we call it severe. So do remember, when it is -2 standard deviation, then it is third percentile. Why? Because we read that between -2 + 2, 95% people lie. So how many people are below -2? 2.5% people. And can we have 2 and 0.5 child? No, na. So we say it roughly third percentile. So third percentile is at -2 standard deviation, not at -3. मैं क्या बोल रहा था? What I was saying in English was कि 95% -2 + 2 के बीच में है, तो -2 से बाहर कितने हैं? 2.5% बच्चे. तो उसी 2.5% को रफली 3% कह सकते हैं ना. तो -2 वाले पे थर्ड परसेंटाइल है, -3 पे थर्ड परसेंटाइल नहीं है, -2 पे थर्ड परसेंटाइल है ना. The same thing which I already said in English, that below -2, because only 2.5% children are there, so we call it at third percentile. And in my family, everyone is like this only. So suppose I bring my girl child, cute Prisa Lakshmi, to you when she is 5 years old, and you plotted her weight for age and it came here, यहाँ आ गया ऊपर. What will you call this patient? What is this patient? What will you call it? Okay, do remember this growth chart plotting. What will you call it? Hey, how dare you call this child obese? Hey, this is my child, Prisa Lakshmi. तुमको जो कहना है मेरे से कहो ना, ये बच्ची को obese क्यों कर रहे हो, है ना? This is normal kid, and not normal because it is my kid. If you got 55 percentile in NEET, you are not a topper. So if you are just above 50 percentile, this is also normal. If it is here somewhere, then it can be obese at all, but just above 50 percentile is normal. Okay, so this is normal. I hope you will remember this growth chart. They ask again and again in PDA, PSM both. Now the question is, if someone weight for height is -1.7 Z, height for age is -2.8 Z, and weight for age is -3.2 Z, this child is acute, severe acute, or chronic malnutrition or wasting, they will ask. So in answering such question, you have to remember two things. First thing, when it is less than -2 or -3, then it is problem. So these are problem or disease. When it is above -2, not a problem. Problem is when it is less than -2. That means if weight for height is 1.7 Z, it means weight for height is normal. And in the severe acute malnutrition, we have discussed that low weight for height is acute malnutrition. So if weight for height is normal, it means there is no acute malnutrition. And if acute malnutrition is not there, first option, which is acute malnutrition, is gone. Second option, which is severe acute, is gone. Last option, which is wasting, is gone. And the answer will be chronic malnutrition. तो क्या आप समझ पा रहे हो इस तरह के क्वेश्चन को कैसे करने हैं? अगर क्वेश्चन में 3 पैरामीटर दिया है, तो आपको ये देखना है कि नॉर्मल क्या है. जो भी -2 से ऊपर है वो नॉर्मल है. जैसे -1.7 नॉर्मल है, और नॉर्मल यहां पर क्या दिया हुआ है? वेट फॉर हाइट को नॉर्मल दिया हुआ है. अब अगर वेट फॉर हाइट नॉर्मल है तो एक्यूट मालन्यूट्रिशन नहीं है, क्योंकि हमने सैम में अभी अभी पढ़ा कि सैम का डिफिनेशन ही है वेट फॉर हाइट लेस देन -3. तो वेट फॉर हाइट कम होना क्या दिखाता था? एक्यूट मालन्यूट्रिशन. और यहां पर वेट फॉर हाइट नॉर्मल है, प्रॉब्लम है ही नहीं. तो जब वेट फॉर हाइट नॉर्मल है, एक्यूट मालन्यूट्रिशन नहीं है, तो एक्यूट वाले सारे ऑप्शन चले गए और आंसर हो जाएगा क्रॉनिक मालन्यूट्रिशन. What I was saying in Hindi was this type of question is done in 2 simple steps. First step is find out what is normal. Here normal is weight for height -1.7 Z. And if weight for height is normal, we already know that low weight for height indicate acute malnutrition. If weight for height is not low normal, it means the child is not having acute malnutrition. And if acute malnutrition is not there, all the option which is corresponding to acute malnutrition is gone, and the answer will become chronic malnutrition. So you have to find what is normal, remove that from the option, remaining will be the answer. Okay, so this child have chronic malnutrition. Now let's go to do this question. Screening family member of hypertension and diabetes in a village is best classified as which type of screening? So if you are screening hypertension and diabetic people, which type of Which type of screening is it? Huh? Can you tell me? Can you give me the answer? Is it anonymous screening? Anonymous screening is something which we do for, let's say, someone is coming to hospital with some other illness, and we do all the general body examination. That is anonymous screening. And we call anonymous screening also as opportunistic screening. That someone came to hospital for any other disease and we use the opportunity to earn money and get more disease, and we did the screening. This is opportunistic screening. Okay. Mass screening, when you will do the screening of the whole village. Okay. Now the question is, it is multiphagic screening or is it selective screening? Okay. So which type will be the answer? Can you give me the answer? What is the answer? Is it selective or high risk? Multiphagic. So, see, can you give it the answer? Multiphagic is a type of sampling. There was a student in Russia who did a study on this, that he asked 22,000 people to touch their thumb at the first line of their ring finger, है ना, like ring finger नहीं, little finger की नीचे की लकीर को अंगूठे से छू सकते हो क्या बिना गैप बनाए? You can see there is a gap when I touch thumb with first line of ring finger. Can you touch it without gap? That was his question. So out of 2,000 people, only 47 people were able to touch it without gap. And then in this 47 people, he did echo, and finally 3 people came out to be mitral valve prolapse. Because if you can touch it, it's not a good news. It means you can have Ehlers-Danlos syndrome, and Ehlers-Danlos syndrome has hypermobility. So if it is hypermobility, the mobility can also be in the mitral valve and can cause mitral valve prolapse. So this type of sampling is multiphagic screening or multiphagic sampling. You did some test, let's say you did first X-ray, then you did ZN smear, then you did CB-NAT. And this is 3 level of thing on the same population. That is multiphagic. And we are not doing multiphagic here. We are not testing all the people, then finding high risk, then testing their children. No, we are doing selective screening there. We are screening the family member of hypertension, diabetes. This is selective screening. I hope multiphase is also clear and you will remember it. But if in the exam they give an image that, let's say in Delhi, you want to know how many children are smoking ganja in class 11, 12. So from the Delhi, you choose 3 area. From the 3 area, you choose 2 colony. From the 2 colony, you choose each colony in, let's say, 4 school. And from each school, you choose 20 children. So this type of sampling is multi-stage sampling. When you do sampling again and again from one area to a small area, that is multi-stage. Okay, so multi-stage is from one city you take different part and you do it. But multiphagic is in the same population you do again and again. Okay. Next question, what is not a component of Anemia Mukt Bharat? I hope you know Anemia Mukt Bharat is a 6x6x6 strategy. बड़ा ही छक्का program है. And in this first 6 is beneficiary, second 6 is the intervention, and last 6 is the institutional mechanism. So it do not include health functionary. But question they are asking these days is, what are the 6 intervention? क्या काम होता है, क्या नहीं होता है? So in the 6 intervention, first is iron folic acid. Second is biannual deworming. That means you will put albendazole tablet 2 times in a year. Third is BCC, behavior change communication and delayed camp cord clamping. Behavior change communication means ऐसी वाणी बोलिए मन का आपा खोए औरों को शीतल करे आप हो शीतल होए. That means we will say to the mother that if you want to make your child come first in the class, take this iron tablet. And all the children have this dream that they should be able to beat every child of the colony. So we will say to the child that if you will drink iron, take iron tablet, you will have solid body. So solid body, smart mind. This is the logo of Anemia Mukt Bharat. This logo will change their behavior. This is the third benefit. After knowing third three benefit, the remaining three can be remembered by double FF. FF double. What does it mean? Double FF. D stand for we will try to do digital HB measurement. Okay. First F is adding iron and folic acid in the food. Food fortification. And last F is focus on other cause of anemia as well. Other cause of anemia like malaria, fluorosis, and thalassemia. So these are the 6 intervention benefit which we give. Okay, do remember this DFF. And in the biannual deworming, when do we do it? 10th of February, 10th of August. 5 days before Independence and 4 days before Valentine Day. तो अगर तुम वैलेंटाइन डे के 4 दिन पहले किसी भी लड़के लड़की से मिलोगे, what will you give them 4 days before Valentine Day? 1 tablet of albendazole. And the girl or boy will ask, ए गोली खिला रहा है, क्या इरादा है? तो तुम क्या बोलोगे? ये तुम्हारे कीड़े मारने के लिए है ना? This is to kill your worm, है ना? Not to make you excited or something. Anyway, what comes 4 days before Valentine Day? Huh? Hug day? Yeah, it's Teddy Day. So what will you give to your Teddy on 10th Feb? Albendazole. That's National Deworming Day. They can ask it also. What is National Deworming Day? That's 10th February. National Deworming Day. Okay. Now, next question is, what is the best level of evidence of research? We have discussed in evidence-based medicine. Best level is meta-analysis. Second is systematic review. Third is RCT. What is the correct sequence of a step in RCT? So similarly, they have asked, what is the correct sequence of event in case control study? So whether it's case control study or RCT, last step is always analysis. Analysis is always last. So that means either answer will be A or answer will be B. Simple. Last step is analysis. Now in the case control study, which actually being asked, the first step is we recruit people. We recruit case and control. And what are case? Disease. Case means disease. And control means without disease. So if any study start with disease, non-disease, that's case control. After recruiting them, we do matching. Matching means if case is a 34-year male, control should also be 34-year male. This is matching. Third step is we take past history. And based on past history, we get cross product ratio. So if they ask this question, in which study we get cross product ratio? Is it cross-sectional study or case control? So cross product ratio is same as odds ratio, which is AD by BC, and it is not in cross-sectional study, it is in case control that we calculate cross product ratio. These are the 4th step. Recruit, match, past history, analysis. Now this is the 4th step. Now in the RCT, first step is we decide exclusion and inclusion criteria, that which people will be taken, which people will not be taken. Then we ask them to choose from the chit AB randomly. And after choosing them, we give some medicine to one group and placebo to other group by not letting them know who are getting medicine, who are not getting it. So this is blinding. So what is the correct step? Exclusion, inclusion, randomization, then blinding, then analysis. Okay, analysis is always 4th. So I hope you will do this 2 question correct. In a field setting, if you are doing malaria diagnosis, which smear will be do for diagnosis of malaria? See, buffy coat can be used, but better is thin smear, because this is the question they will ask. Which slide tell about? No. Let me make it clear. This is not the answer. What I am trying to ask you is, Which smear tell about species of Plasmodium? Is it thin smear or thick smear? So thin smear tell about species, and thick smear only tell about Plasmodium present or absent. So who tell about species? Thin smear. Okay. Now, second question which came from this part is, what is histidine-rich protein will detect? Will it detect Vivax, falciparum both, or only falciparum? So, histidine-rich protein detect only Plasmodium falciparum. कैसे याद रखोगे? Plasmodium falciparum से इतना सीरियस इन्फेक्शन होता है कि पेशेंट मर सकता है, हिस्ट्री बन सकता है. तो जिसमें हिस्ट्री बन सकता है उसी में histidine-rich protein है. Because of Plasmodium falciparum, patient can die, become history. So only in that we use histidine-rich protein in falciparum only. Okay. RDT test is something which is done by ASA. ASA also have RDT kit. And thin and thick smear is made by MPW. How MPW make it? By active surveillance. Active surveillance is for hidden case. MPW go from door to door and will ask, does anybody have fever in the house? Once in 14 days he will visit and he will make 2 blood smear. So he is searching hidden case. This is active surveillance. And who does it? Male multi-purpose worker, which is health worker male. But the MPW who make the slide, he then send the slide to PHC. And PHC have a lab technician who will examine and find the report. So if you are asking about field setting, smear can be made in field. But the making of smear will not start the treatment. For treatment, we need to send it to the PHC and all. So in the field setting, like ASA is visiting, how he can make the diagnosis? He can make the diagnosis by rapid diagnostic test kit. Okay. So in the field setting, we are making diagnosis through RDT kit. We are collecting the smear, but it is making diagnosis after the smear goes to PHC, and then PHC will make the diagnosis. Okay, not sudden. Plus one more question, there are multiple questions which come from this part. One more question which come is, if they gave you headphone-like gametocyte, this headphone-like gametocyte, is it falciparum or vivax? So headphone or banana, both are falciparum. Headphone and banana are falciparum. And if the gametocyte is granulated, then it will be vivax. So granulated will be vivax, headphone banana will be falciparum. Okay. So next question is, which of the following is not high risk for HIV? Does doctor are considered as high risk for HIV? Hey, don't give yourself too much of importance. You are not high risk for HIV. You have not performed that well. Sex worker come under it. So first is sex worker. Second is transgender. Third is male having sex with male. And fourth is IV drug user. These 4 are high risk for HIV. Can you remember it? Why MSM जानते हो ना, आदमी हूं आदमी से प्यार करता हूं. Why MSM and transgender are high risk? Because they go for unprotected anal sex. So they are high risk. Who is not high risk? Distance truck driver and migratory worker. They are bridge population. Because truck driver and migratory worker, they stay away from their wife, they go to sex worker, and from the sex worker, which are living in separate part of society, they take HIV and spread it to general female population. So they're acting like a bridge. So who are high risk? MSM, transgender, sex worker, and drug user. Only 4 are high risk. Okay. One more thing they can ask is, based on this sentinel surveillance of collecting data from different people, we know the trend of HIV. Sentinel surveillance tell us trend of HIV. And based on that, we decide state into different group. So what are moderate prevalence state for HIV? Moderate prevalence state is those in which high risk group has more than 5% HIV and ANC less than 1%. How will you remember it? Tell me one thing. Which one is more dangerous? In high risk group, if 6 out of 100 is positive, sex worker is 6 out of 100 positive, that is what we are expecting. But in general population, if 2 pregnant female out of 100 is positive, that is more dangerous. So first we reduce ANC. ANC should be less than 1. First focus should be on ANC. It should be less than 1 in moderate prevalence. Okay, that's there. Now, which of the following is incorrect about rotavirus vaccine? First is, it is available as monovalent and pentavalent vaccine. Yes, it can be available in multiple combination. It is not recommended after 6 months. This is also correct. Second dose we cannot give after 6 months. We cannot give rotavirus after 6 months. Second dose we cannot give. It is a subunit vaccine. This is wrong. Subunit vaccine we already discussed. P for protein, P for pertussis is subunit. And of course we give it oral route. Okay. Now let's do this one question which came on this topic. After taking pentavalent, you gave pentavalent to a child. He had fever more than 40 degree. In next time, what will you do? Fever more than 40 degree or convulsion or unconsolable cry. All these three things occur as due to pertussis component. Problem in DPT is only due to pertussis, not due to D and T. Therefore, in the next visit, what you will do? In the next visit, remove the thing which is causing problem, remove pertussis, and you can give DT. Because there is no problem with DT. Some of the different places, they say that continue giving pentavalent. No, fever more than 40 is a contraindication. And if contraindication occur, next time you cannot give pertussis. So you remove pertussis and give DT next time. Okay, that's correct answer. Now, which is not a polysaccharide vaccine? Not a polysaccharide vaccine. We already know hepatitis B is a recombinant vaccine. Pneumococcal, meningococcal, Haemophilus influenza, these all are polysaccharide vaccine. And there is one more polysaccharide vaccine, VI polysaccharide for typhoid. So these four are polysaccharide vaccine. Okay. And in the meningococcal vaccine, they use ACY W135 subunit. So they have asked the question, which subunit is not present? A, B, C or Y. People think A, B, C, then D should be there. They took Y not there. No, B subunit is not there. ACY W135 is there. Beta subunit not there. Okay, absent. So I hope you will remember beta subunit is not there. Now, next question is that there is a 5-year-old child. So we already discussed it, that because weight for height is normal, so acute malnutrition option are gone. Answer is chronic malnutrition. Now, although this is part of pedia to discuss pneumonia and diarrhea, but PSM Park has also given the classification, and I can go anywhere. I want you to teach only 3 points about pneumonia. First point is, if you can see stridor in a calm child, stridor means while breathing, different type of sound come while breathing. I cannot make it properly because I don't have it. So if there is a stridor or danger sign, what are the danger sign? Convulsion, danger sign are convulsion, cyanosis, fever more than 40, non-responding, lethargic nahi, non-responding ekdam, repeated vomiting, not drinking, these all are danger sign. So if danger sign or a stridor is there, you don't label it as red. There is nothing red. We label it as pink. We give IV gentamicin antibiotic and we refer the child after giving IV gentamicin antibiotic. But if it is pneumonia, pneumonia will have chest indrawing or fast breathing, any one of them or both of them. We give amoxicillin and we classify it as yellow. So this is the question being asked. What is the drug of choice for pneumonia? Amoxicillin. And which category you will level? Yellow. Chest indrawing means just below the chest, in this area, there will be deepening. यहाँ पे गड्ढे पड़ जाएंगे ना, below the, in the diaphragmatic region, there will be deepening while breathing. That is chest indrawing. And fast breathing, this you have to remember. When do you call it as fast breathing? So fast breathing is very easy to remember. We can remember it very quickly. See this here. In the fast breathing, first thing is, sorry, it went somewhere. First thing is, if the age is 2 months to 1 year, if the age is less than 2 months, more than 60 per minute is fast. 2 months to 1 year, more than 50. And more than 1 year, more than 40. So 60, 50, 40. 2 months to 1 year, 50. More than 1 year, 40 per minute is fast breathing. Okay. So if there is a question given like this, suppose age is 6 months, Respiratory rate is 64. 64 means fast breathing, na? Because 6 months it should be 50, and here it is 64, more than 50. So that means fast breathing is there. Chest indrawing is absent, but fast breathing there. So any one thing is there, you will classify them as pneumonia, and you will give the drug of choice amoxicillin. Okay, so this is for the question which come from the topic of pneumonia again and again, and I hope you will be able to do it correctly. Okay, now let's discuss a bit about diarrhea also. When we talk about diarrhea, they have asked this question already: which of the following is seen in some dehydration? So we have to know severe and some dehydration. There is nothing like mild, moderate. Severe, some dehydration, or no diarrhea. Just like severe pneumonia, pneumonia, no pneumonia. So in the severe dehydration, two of the following signs will occur: lethargy, sunken eye, not able to drink, skin pinch, goes back very slowly. Very slowly means more than 4 seconds. And in severe dehydration, we give IV fluid. Remember, ringer lactate is the fluid of choice in burn patient, and ringer lactate we use in severe dehydration also. Okay, and how much we give? This is a pediatric thing, but we give 30-70. Enough. We divide them and then we give it in half hour 30 ml, and then 2.5 hours we give 70 ml. Like that, 30-70, total 100 ml per kg we give. So in the severe dehydration, these are the 4 things you have to remember. 4 things, you can use the word LSD. Suppose the child has taken LSD, and due to taking it, he is not drinking. So LSD, not drinking. What is L? Lethargic. Skin pinch very slowly. P means not drinking, and sunken eye is common. Sunken eye, if you will go to some dehydration also, there is sunken eye. So sunken eye is in both of them. If it is LSD, lethargic, skin pinch very slowly, and not drinking, it is severe dehydration. If it is RSD, RSD means child is restless, there is skin pinch going slowly, sunken eye will be there, but this time child will drink eagerly, प्यासे की तरह पिएगा. This is yellow. Pink is severe dehydration, yellow is some dehydration, green is no dehydration. And in yellow, because the child is drinking eagerly, we will give ORS from mouth. We need not to give IV ORS or IV fluid. Okay. So, which is seen in some dehydration. Remember, what is the mnemonic of some dehydration? RSD. What is R? R means child is restless. So, lethargy is gone in some dehydration because child is restless. S means sunken eye. So, sunken eye is there, correct. S is also for skin pinch, which is slowly. Delayed skin pinch less than 2 seconds. Slowly is some dehydration, very slowly is severe dehydration. So this is also correct. And D means the child is drinking very eagerly, drinking restlessly. So restless drinking, that means thirst is there. So A is there, C is there, D is there. Decreased urine output is not a criteria because we are unable to measure urine output in child properly. So we don't use it as a criteria. So answer is A, C, D, thirst, delayed skin pinch and sunken eye, and hope you will remember pink, yellow, then green is there. Pneumonia and diarrhea is not my area, but because it is asked again and again, I was forced to discuss it. What is the best test used for malaria parasite species detection? Again, one area which is in micro also, but Ghayamja stained thin smear. This will be the best to know the species detection. First of all, species is not by thick. We have already discussed. Thick will only tell malaria present or absent. Thin will tell about species better. And Ghayamja stain is gold standard. You can see this. Gold standard, G for gold standard, G for Ghayamja. So better will be Ghayamja than acridine. And acridine is good for screening. In rapid high burden area, if they said we will use acridine orange for emergency cases and very high. But if it is fluorescent microscopy available, then acridine is good. But in India, where is fluorescent microscopy available? Very rarely. So we go for Ghayamja. Okay. And Buffy coat also we do. But better gold standard is always Ghayamja. So that's why correct answer for species is Ghayamja and that too thin slide for species. If a farmer present with high grade fever, vomiting, retroorbital pain, myalgia since 5 days, retroorbital pain, frontal headache, this is clearly indicating of dengue. So this farmer has dengue. And what investigation can do if the fever is already for more than 5 days? Up to 5 days, we do NS1 antigen test. But the patient has already fever for more than 5 days. So here the better answer is IgM ELISA. If they say exactly 5 days, better answer will be IgM ELISA. If they day 4 days and all, answer is NS1 antigen. क्योंकि 4 दिन तक तो एंटीजन ब्लड में रहता है, कॉन्सेंट्रेशन हाई रहता है. 4 दिन होते होते उसका कॉन्सेंट्रेशन NS1 एंटीजन का इतना कम हो जाता है कि वो डिटेक्ट होना मुश्किल हो जाता है और डेंगू होते हुए भी फॉल्स नेगेटिव रिपोर्ट आ जाता है कि डेंगू नहीं है. What I was saying in Hindi was that antigen concentration in first 4 days it is there, but after 4 days it becomes so low, the antigen concentration, that report usually came false negative. So that is why after 5 days or till 5 days you can give IgM antibody test. Till 4 days we can go NS1 antigen test. Okay. And if there is second infection with different serotype of dengue virus, then it will be more lethal because this is known as antibody dependent enhancement. Okay. आपने देखा होगा कि कभी कभी कोई पॉकेट मार वगैरह मूवी में दिखाते हैं कि पॉकेट मार वगैरह जेल गया तो पहली बार तो थानेदार उसको ठोक ठोक के लाइन में लगाता है, सब रूल सिखाता है. लेकिन दूसरी बार वही पॉकेट मार जब जेल में जाता है तो वही थानेदार उसके साथ बैठ के बीड़ी फूकता है कोने में ले जाके, है ना. उसी तरह से जब दूसरा बार डेंगू का इन्फेक्शन होता है तो एंटीबॉडी जो सिपाही है वो उसको चोर समझने की जगह अपने साथ अंदर ले जाता है और मल्टीप्लिकेशन में हेल्प कर देता है. तो सिपाही की वजह से इनहैंसमेंट हो गया, बुखार बढ़ गया, इसलिए डेंगू का दूसरा इन्फेक्शन जानलेवा हो सकता है. अगर वो डिफरेंट सेरोटाइप से होगा तो, सेम सेरोटाइप से होगा तो ज्यादा प्रॉब्लम नहीं होगा. ओके. और डेंगू के 4 सेरोटाइप डेंगू वायरस वैक्सीन में है, टोटल 5 सेरोटाइप आइडेंटिफाई हो चुके हैं. व्हाट आई वाज सेइंग इन हिंदी वाज दैट sometime you must have seen in some movies and all that when a thief come, the guard and all, they teach him all the rule and be very strict with him. But when the second time the same thief came, the guard take them inside and smoke bidi with them. So this is the same thing happening with dengue virus. When second infection occur, antibody take them inside and help them in their multiplication. That's why it is known as antibody dependent enhancement, which occur with dengue. Now, which of the following is associated with sexual dysfunction? Do remember, answer is zinc. Zinc lead to 3 problem. All 3 has been asked in different exam. First is hypogonadism, छोटे टट्टे. और टट्टे हम लोग कभी भी एक दूसरे से कंपेयर तो नहीं करते हैं, कभी भी मैंने नहीं देखा कि कोई दोनों टट्टे कंपेयर कर रहा हो. We never compare our scrotum or testis with anyone. So even if it is there, it is difficult to diagnose from outside. That is why राष्ट्रीय बाल स्वास्थ्य कार्यक्रम, in which Ayush doctor is going for the screening, they cannot screen for zinc deficiency because they are not going to compare the testicle. Delayed wound healing is also due to zinc, but we blame it on infection and all. And dryness around nose and mouth is something which is so common that we don't think it is zinc deficiency. So do remember, RBSK do not include those diseases which need instrument for detection. Like glaucoma, only 10% case have ophthalmos can be seen from outside. 90% case we need to have gonioscope to measure the eye pressure, or we need to measure optic nerve thickness before deciding. So these type of disease which need instrument, they don't come under RBSK. And do remember, zinc cause these 3 problems: dryness around nose and mouth, delayed wound healing, and hypogonadism. Now, which anti-leprosy drug caused skin hyperpigmentation? That is clofazimine. Clofazimine caused 2 problems: opacification of lens, cataract-like changes, and skin hyperpigmentation. Now they have asked in past, what is the drug of choice of lepra reaction? It's not thalidomide and all. The drug of choice for lepra reaction is methylprednisolone, and when we give this methylprednisolone, we continue giving multiple drug therapy for leprosy. We don't stop MDT and give prednisolone, we continue it. Now there is one controversial area which I want to intervene. And because students are asking again and again, sir, is there any day update on that or anything like that? So this is the recent updated information. Do remember, if they ask, what is the minimum education for ASA? Answer is 8th pass, not 10th pass. This is not me telling you, do not trust expert. Expert can be biased. I am always again and again telling you, trust on evidence, not on expert. And the evidence in this part is nothing better than the PAAR itself. And PAAR has written this thing in 3 places, that 3 places they have written that ASA should have minimum formal education up to 8th class. 8th class. They don't even talk about 10th. So then why some teachers are teaching 10th? Because they have Googled it, and on Google they write 10th. But if exam setter is preparing question, they will not go to Google to prepare it. And recent PAAR has written 3 places, so please trust it. It is 8th class, and there is only one ASA for 1000. Please don't doubt it. If you want to doubt it, you are doubting PAAR, and you are doing your own injury harm. So don't doubt it, because it's evidence-based medicine which you have to follow. Urban USA is ASA. Urban USA or ASA is at 1000 to 2500 population. Roughly you can say Urban USA is at 2000, ASA is at 1000. Okay, and there is only one ASA per 1000. It's written there. You can see that. Okay. Chalo. Now let's come to Ayushman Bharat. You must have seen the logo of Ayushman Bharat with 5 green leaf. Same 5 green leaf also occur in marijuana plant. So what the government want to tell us? Why there is 5 leaf? To tell us 5 lakh rupees which is given. So the question which I am willing to ask here is that in the school health program, which one is not included? That is my question. A school health program can give sanitary pad. School health program do give albendazole, but we never give IFA monthly. We give iron folic acid either once a week. For once a week we give for 3 group, 5 to 9 year, 10 to 19 year, and adult female. 3 group we give once a week tablet. You can remember it with the mnemonic PBR, pink, blue, red. Just like PVR, movie are released in PVR once a week, na? So similarly, pink, blue, red are given once a week. Pink is for 5 to 10 year children, blue is for 10 to 19 year, and R is for adult female. Pink, blue, red. This is PBR. And all this are given once a week. PBR, once a week. So we never give monthly, that is gone, of course. Now, they ask a lot of questions from a school health program. Do remember, school health service, who do the screening? Doctor don't go to do the screening. Teacher screen children for refractive error. And school health services is included in Ayushman Bharat also. It is also included in PHC Vision Center. Do remember, school health service do come under both. Why it come under Ayushman Bharat? Because in Ayushman Bharat, we have PMJ, which is 5 lakh insurance, Pradhan Mantri Jan Arogya Yojana. Second component of Ayushman Bharat is Health and Wellness Center. In Health and Wellness Center, we are going to change sub-center and PHC into Health and Wellness Center, and we will give them 8 facility, new 8 facility. Very easy to remember. What are the new 8 facility if they ask? One is dental, other is mental, psychiatry and dental. Second is ENT opthal, which is always together. Then there is old age and palliative care facility. 7th is trauma, and last is yoga, because yoga se sab hoga. So these are the 8 new facility which will be given, and sub-center will be changed into Health and Wellness Center. The third component of Ayushman Bharat is school health service itself. Because in school health program, now the government say that every Tuesday we will celebrate Health and Wellness Day. This Health and Wellness Day will be celebrated in Tuesday, because if it is celebrated on Tuesday, it will help in propaganda. Tuesday is, remember, Hanumanji Day, hai na? So they will make yoga associated with Hindu religion and then with BJP and all. So this is a way to do propaganda, because in yoga you are not spending any money, you are not giving anything from your side, and you are telling that I am giving something. So in this Health and Wellness Day on Tuesday, they will select Health and Wellness Ambassador, which is male and female teacher, and Health and Wellness Messenger, which will be boy and girl student. Why they will select them? To do couple yoga? No. To teach yoga and meditation to other people. So this is messenger, which are a student, ambassador, which are teacher. This is on Tuesday. We celebrate Health and Wellness Day. Okay. Now, a friend sent report of brother, his family. I hope you know this question already. Coproporphyrin test is done. So if coproporphyrin test is done, this is plumbism. Do remember, what is the most common route of lead poisoning? this is inhalation. And what is the drug of choice for lead poisoning? Ethylene diamine tetraacetate. Along with coproporphyrin in urine, second test which they can ask is aminolevulinic acid in urine. Two tests we do for plumbism: coproporphyrin, aminolevulinic acid. Plus, there can be basophilic stippling in the RBC, there will be basophilic granule, and there will be blue line on upper gum, Burtonian line. So these are the things: Burtonian line, basophilic stippling, coproporphyrin, and aminolevulinic acid, which you will find in lead poisoning, which is most common route is inhalation. Then they have asked this question: which has maximum submerged portion of iceberg? Submerged portion indicate those people who recover without symptom, who don't go to hospital. So if hidden part is more, it means more people are recovering without symptom, and influenza have it like this. In influenza, we recover without going to hospital. But in 5 disease, no one recover without going to hospital. Like rabies. Other than rabies, there is measles, tetanus, neonatal rubella pertussis. In these 5, no subclinical, no hidden part is there. No one recover without symptom. If I am bitten by rabid dog, for 3 months I can remain hidden, but ultimately I will go to hospital. And when I will go to hospital, I will be reported and the tip, because the tip represent clinical case. So rabies do not show iceberg phenomena, because in rabies no one recover without symptom. Everyone will have to go to clinic, and when they will go to clinic, they will be reported. Okay, so these 5 diseases do not show iceberg phenomena because they don't have subclinical case. And influenza has maximum hidden part of iceberg phenomena. Okay, now with rubella, they can ask this question. They have asked it in NEET 2023. One is congenital rubella syndrome, which occur, have 3 things. I hope you all know: sensory neural hearing loss, patent ductus arteriosus, and congenital cataract. But if the female develop rubella in 12 to 16 weeks, then she will have only sensory neural hearing loss. And if a pregnant woman like me who developed it after 16 weeks, then we need not to worry. There will be nothing, no complication. So we will only reassure the mother. Okay. And do remember one more thing about measles. If you vaccinate 95% of children for measles, remaining 5% will also be protected and measles will be eliminated. How measles will be eliminated? It will be eliminated due to herd immunity. झुंड की इम्यूनिटी के चलते मीजल्स चला जाएगा, क्योंकि 95% बच्चे वैक्सीनेटेड है, तो अगर बीच में कोई अनवैक्सीनेटेड बच्चा भी है तो वहां तक मीजल्स पहुंच ही नहीं पाएगा, because 95% children are vaccinated. So even if one child is unvaccinated in the center of a herd in which all are vaccinated, the infection will not reach to that child which is in that herd. So in herd immunity is protecting remaining 5% children, and measles can be eliminated. But do remember this concept of herd immunity. This herd immunity don't apply for rabies and tetanus, because rabies and tetanus, they are not transmitted by fecal-oral route or respiratory route. If everyone is vaccinated for rabies and dog came and bite my bum, even if I am living with many people who are vaccinated, I need to take rabies vaccine separately, because I am not protected by herd immunity in rabies and tetanus. Okay, 2 things which don't apply for herd immunity. Okay. So now this question on MTP we have already done. If female is at 22 weeks of pregnancy, rape victim, we can do MTP, and in doing MTP, we need the doctor of permission. MTP can be done up to 24 weeks in this case, not after 24 weeks, because after 24 weeks, we do it only in congenital anomaly present. Okay, so we can do it up to 24 weeks in this case, but after 24 weeks only in case of congenital anomaly we do, not in that. This is very important to remember disaster cycle. And when it comes to disaster cycle, this is the table from PAAR. We can remember it by the mnemonic RRR MP impact. And suppose, let's say after the RRR movie was celebrated, they went to MP Ujjain, and in Ujjain, if you go and come out from Mahakal temple, there is a shop which are selling marijuana leaf with milk and all, thandai shop. So suppose they take that marijuana, and if you take it, there will be impact. So the mnemonic is RRR went to MP, had marijuana and had the impact. But the main work is to remember what is that RRR. See, first R is response. We will respond them, we will try to save them. Second R is rehabilitation. Rehabilitation means we try to make them self-dependent by giving them job. So second is rehabilitation. After making them self-dependent, by giving them some job. And which job you can give them? You can give them the job of construction. So the last R is constructing their houses. So first rescue, then job, rehabilitation, then construction. And these three will together become recovery. Okay. Then there is mitigation. Mitigation means decreasing impact of future disaster. Like this question has come that if you are trying to make earthquake proof houses, you are decreasing effect of future disaster. That is mitigation. And then we prepared rescue team, warning signal and all. And whether you are prepared or not, next impact will come. So triple R, MP impact. But remember, in that triple R, first R is save, rescue, then rehabilitation, then reconstruction, then mitigation, preparedness. Do remember the cycle. Now, a study undertaken to establish that vegetarian and non-vegetarian diet with disease are like this, that vegetarian diet have more disease or non-vegetarian diet have more disease. So first thing they're talking about disease. What is the outcome? Disease. And we already have said that disease means qualitative data, categorical. And in qualitative, which test we apply? Chi-square test. So answer will be chi-square because here we are talking about disease outcome. Okay, we already have discussed that coefficient of variance compare quality of data. Correlation tell us direction of association between two variable, that which variable, like if we are talking about heart attack and hypertension, both are positive correlated. I have showed you. So direction is by that. And pair t-test we will answer if it is pre, post, before, after match word written. We have done this question. So it's there. Now, next is which is not a component of PQLI. PQLI and HDI, they again and again asked how to remember it forever so that we don't forget it in the exam pressure. Two questions in recent it came from this topic. So very important topic. See, first thing is when you write PQLI, can you write LI as L1? L1 means life expectancy at 1 year. So PQLI is life expectancy at 1 year. First thing done. Second thing, PQLI is 4-letter big, so the range is also big, 0 to 100. HDI 3-letter small, so the range is also small, 0 to 1. And L1 is first step to remember. Second step is PQ is for poor country. HDI is for highly developed. And in which country will you measure literacy rate? For poor country like India, literacy rate matter, or for highly developed country like England, literacy rate matter? अरे इंग्लैंड में तो बच्चा बच्चा इंग्लिश बोल रहा है. We don't need it in England because there is high literacy. We need literacy rate for poor country. So poor country second criteria is literacy rate. First criteria is life expectancy at 1 year. Then the third criteria is infant mortality rate for PQLI. So which is not a criteria of PQLI, gross national product. Let me again explain it with example. Gross national product or per capita income. This matter for India per capita income or Russia. In India, 2% people have 90% of India wealth. So when we measure per capita income in India and include those 2% people, our per capita income will be respectable. If you remove that 2% people, our per capita income will go under the ground. So per capita income do not matter for poor country because it only depends on 2% people. When the news channel says that, let's say Gujarat per capita income is increasing, it's actually Adani per capita income which is increasing, not the whole Gujarat. You understand the point? So when they ask per capita income question, it is matter for highly developed country like Russia, not for poor country like us. For us, it matter is infant mortality rate. So when it comes to highly developed, we measure life expectancy at birth. PQLI1 is PQLI, birth is HDI, per capita income, and mean year of schooling is the third thing. So do remember HDI, PQLI separately again and again ask. Okay. Now, a patient does not understand meaning of doctor. This is again a question being wrongly told by many teachers. Patient does not understand meaning of doctor word. What type of barrier is it? Doctor simply answered it is linguistic. But in the PAAR textbook, there is nothing like linguistic barrier. Barrier of communication is either physiological, psychological, environmental, or cultural. Physiological means if someone has difficulty in hearing, problem is medical. Medical problem, body problem, body is the problem, that is physical, physiological. Body is the problem. Psychological, because let's say someone is emotionally disturbed or neurosis is there, that is psychological. Environmental, let's say the OPD hospital is near to metro station or railway track, noise is there, congestion is there, many patients are in the OPD, so environment is problematic. But it is cultural when due to level of knowledge and understanding you are unable to understand, then it is cultural barrier. So let's revise it. Physical, problem in hearing, listening. Psychological, patient is in emotionally disturbed, neurosis and all those things. Environmental, more noise, more pollution, they are environmental. And cultural is when the culture is different, someone is more educated, someone is less educated. This is the problem. So here the barrier is actually cultural, because you are not able to understand the meaning of word due to the level of, see this, language variation is there, social class difference is there between urban education and rural population. So if you are unable to tell the people because you are more educated, your language is different from their language, this is cultural, not linguistic. Okay, so urban education different than rural, it can be linguistic, but linguistic come under cultural. It's not a separate classification. So physiological, psychological, environmental and cultural, and better answer will be cultural according to PAAR. Next is, they can give you the question from demographic cycle. And do remember, in the demographic cycle, this question has came in MCI, that which two phase has high birth rate. So high birth rate is in both phase 1 and phase 2. Both have high birth rate. Okay. High birth rate is in two phases. Birth rate start decreasing from third phase, late expanding. And in low stationary, it is very low. Then finally in declining, you all know declining is because birth rate become less than death rate. So now if they ask you what does this black line represent, the lowermost line, this black line is death rate, that will be the correct answer. If they ask what is this green line represent, this green line you can see is representing population growth. This is population growth. Let's zoom it. Then the red line is the birth rate, and red line is the birth rate. And they can ask you one more question, that in which phase of demographic cycle maximum growth rate is there. So I hope you all know growth rate means birth rate minus death rate by 10. Why we divide by 10? Because birth rate, death rate are in 1000, growth rate is in 100. So we divide birth rate and death rate with 10. So maximum growth rate is in which phase? It is in late half of early expanding. Okay, late half, you can see in late half of second phase early expanding maximum growth rate. And second question they can ask is, when does growth rate start decreasing? So growth rate start decreasing in early half of third phase. You can see in early half of late expanding growth rate start decreasing. And then they can ask in which phase India is there. So India right now in late expanding third phase. So our growth rate is already decreasing, and you need not to worry about growth rate. You can produce as many children you want. Okay, so this is the demographic cycle from which they can ask it again about leveling. Do revise it. Now, a pregnant lady deliver a baby, earliest time which we can insert is within 48 hours. But maximum time, if they ask, up to which time we can insert, it is 6 to 8 weeks we can insert. Maximum is 8 weeks. Earliest is within 48 hours, that we call as PPIUCD. And PPIUCD is not ideal. If they ask what is the ideal time, PAAR has written it that the ideal time, you can see it here. The most propitious or ideal time for loop insertion is when the female is within 10 days of beginning of menses. So within 10 days of beginning of menses is the best time. Then if you insert it just immediate to postpartum, it can lead to perforation of uterus. It can also lead to high expulsion rate. So we should not try to insert it just after birth because it can create many problems. But government say do it just after birth. Because people who say these things, they are sitting in their AC room in Delhi. They don't know the ground reality. So they say such weird thing that put it just after birth. And plus their more focus is on controlling national population rather than thinking about female. But now, right now, as I said, our growth level, our target total fertility rate is 2.1 and we have achieved TFR of 2. 2 child per female is already there. So we need not to focus much on population control. We have to care about the female. So don't insert PPICD in practical. But in theory, you can give it. But it's not the ideal method because PAAR has written there is 2 complications in it. Okay. So, and we can insert it up to 6 to 8 weeks. Okay. So it's there. Now, a student was also asking me the question on mean, median, mode, how to calculate it and all. It's very simple. Let's say you have any data. Suppose the data is 4, 6, 8, 9, 9. If they ask to find the mean, you simply add all of them, divide them by 5. So if you add all of them, 4, 6 is 10, 9, 9 is 18, 18 and 10 is 28, 28 and 8 is 36, 36 by 5, it will come 7.2. And you can see 7.2 is roughly in the center. Can you see 7.2 roughly here? It's roughly in the center. So mean is most commonly used. What we use most commonly? Mean. What is median? Median is middle number. 8 is the middle number. So median become 8. But it is median only, 8 is middle number only after arranging the number. And what is mode? Mode, just like model, keep repeating itself, keep appearing in different TV screen and serial. So mode keep appearing again and again. And here mode is definitely 9. So mode is 9, median is 8, mean is 7.2. But in the same question, if they make it 4, 6, 8, 9, 9 and 89 or your favorite 69. Now what is the median if they ask? So in this case, there is 2 number here, 2 number here. In center, there is no number. 8 and 9 are both in the center. So if you cannot find one number in the center, you need to take average of that. And average of 8 and 9 will be 17 by 2 or 8.5. So median will become 8.5. So median is calculated like this. And do remember, you can see median is not affected by big number. In place of 89, even if they place 9, median will remain same. So median is not affected by big number. Okay. So now they ask many times a separate question by this thing. They will ask that, okay, if the distribution is 2, 3, 4, 4, 5, 6, 7, 8, median we can find is 4.5. Okay. But let's say our distribution is something like this: 2, 3, 4, 4, 5, 6, 98. This is the distribution. And I change 98 with 38. So when I change the big number, which one is affected? Mean is affected, mean will decrease. But median will remain same. If I change 98 with 38, एक बात याद रखना, median बीच का है. Median always remain in the center. Median is not affected by big number. So when you change 98 with 38, median will remain same. But mean is mean minded. Mean छोटे दिमाग का है. जहां भी बड़ा नंबर देखता है ना, उसकी ओर खींचा चला जाता है. Mean get attracted towards big number. So if you are changing big with small, mean will decrease. Because big number is changing into small, mean will decrease. Median will remain same. Okay. So I hope you will remember. And if they give this type of distribution 2, 3, 4, 5, 6, 98, and they ask which one is better to use, mean, median or mode. If there is very big number, better to use is median. Because mean get deviated towards big number, mean is mean minded. So in distribution with big number, we always use median. Okay. So I hope you will remember it. Now, this is just the same thing which I already discussed, when to apply ANOVA and all those things which we have discussed. This instrument is being asked again and again. This is kata thermometer. Kata laga, Kata is sharp and pointed, so that is long one is kata, and if they give you this circular one will be globe thermometer and all. So globe thermometer will be measuring the radiant heat. Radiation temperature is measured by globe. This type of circular is globe thermometer, and globe thermometer measure radiant heat. Kata measure two things: cooling power and air velocity. Now this time they ask, and most of the students said only one thing was in the option. But suppose they ask the question and keep cooling power, air velocity both in the option. Which one is better to answer? Will you answer cooling power or air velocity? Better is air velocity. Do remember, if they ask Kata thermometer used for cooling power or air velocity, you will answer air velocity, because Park has written is that Kata thermometer is now largely used as anemometer for recording low air velocity rather than cooling power of air. So now Kata is mostly used for low air velocity. Okay. Now in your exam also they have asked this question with this type of thing. This instrument is sling psychrometer. Now we hold it from this handle and then it go in the room like this, up and down, upper niche, and it rotate in the room and measure humidity of the air. So this is sling psychrometer. Psychro word means humidity, so that will measure humidity. And if you give this type of instrument, ऐसा नहीं लग रहा है कि ये किसी के आसमान में घुस जाएगा? Doesn't it look like a proctoscope going into someone's ass and all? So this is assman psychrometer. And wherever there is psychro measure humidity. So these are the four instruments. Let's revise it. Kata thermometer, cooling power, air velocity, better is air velocity. Globe with measure radiation temperature. And sling and assman psychrometer radiation measure humidity. If you look at my name also, it is Ashwani. So this is humidity, which is psychrometer humidity. Okay. So this is their globe radiation temperature. We already have discussed. Now, let's discuss this question. Which vaccine is kept at lowest level? Storing the vaccine is very confusing, but Park has clarified it very simply. See, Park simply say vaccine like OPV, BCG, measles and JE. These are the vaccine which are kept in the basket with ILR. It is kept in ILR. Unlike higher level vaccine stores where it is kept in deep freezer, can be kept at bottom of the basket, while DPT, TT, Hep B, IPV and pentavalent vaccine and Dalvent are kept in upper part of the basket. So कैसे याद करेंगे इसको कि कौन नीचे है कौन ऊपर है? देखो, all tetanus vaccine are not live vaccine, so they don't need to be stored exactly in cold temperature. That's why many shop has tetanus vaccine. So all tetanus can be stored above. Along with tetanus, there is Hep B and IPV. That's all. Only this four you have to remember. All tetanus, Hep B and IPV, these are kept in upper part. So upper layer of ice-lined refrigerator have all tetanus, Hep B and IPV. In the lower part, we have vaccine like OPV, BCG, measles and JE. All the live vaccines, they are kept in the lower part where we need more cold temperature. So what are in the lower part? Live vaccine, OPV, BCG, measles, JE. OPV, BCG, measles, JE, lower part. All tetanus, Hep B, IPV, upper part. Okay, now let's go back to the question. Which vaccine is kept at the lowest part? OPV is lowest part. We discussed Hep B, DPT, these are in the upper part. Rota we have not talked about. So what is the vaccine in the lowest part? OPV. Along with OPV, what are there? BCG, then there is JE, and one more live vaccine, OPV, BCG, JE and measles. OPV, BCG, JE and measles, these are kept at lower part. Then there is one more area which question come again and again, open vial policy. That simply means that there are some vaccine which we open and we can use them up to 4 weeks of opening if they are stored adequately between 2 to 8 degrees Celsius. So if in some vial they read that store at cool place, store at cool place means what? 2 to 8 degrees Celsius. Cool place means 2 to 8 degrees Celsius. So these vaccines should be kept in 2 to 8, then we can use up to 4 weeks. Now question they ask is, which vaccine follow open vial policy, which do not follow it? So to remember it simply, we can remember it like this. Just say it with me and you will remember it. B, PCV, all tetanus, all polio. Say it. Hep B, PCV, all tetanus, all polio. These are the vaccine which follow open vial policy. एक बार में याद हो जाएगा. Hep B, PCV, all tetanus, all polio. So all tetanus include DT, DT, TPD, Penta. We cannot need to remember them again. All polio include OPV, IPV. So Hep B, PCV, all tetanus, all polio, they follow open vial policy. Okay. They do revise it before exam. Hep B, PCV, all tetanus, all polio. And in one of the exam, they ask it that in one's vaccination center, you opened pentavalent and measles. In next session after 1 week, which one will you throw, which one will you keep? So we will keep the penta in next session because penta follow open vial policy, but we will throw MR because MR do not follow open vial policy. So in next session, next vaccination session, we will keep those who follow open vial policy, and they are Hep B, PCV, all tetanus, all polio, and we will throw those who are not following open vial policy. Okay. Chalo. Now, if you want to know the effect of vitamin C on respiratory disease, we are doing a case control study, and we already know how to do case control study. First is we will select case and control, then we will do matching. After that, we will take the past history, and last step is analysis. Okay, so we will do that. Incubation period is 5 to 14 days. What is quarantine period? I hope you all know. Quarantine period is something, quarantine, this was a separate question also. It is done till maximum incubation period. And here the incubation period, which is maximum, is 14 days. So till 14 days, we will keep them in the quarantine. If they ask about isolation, isolation is done till maximum infectivity period. Okay. And quarantine we do on healthy people or sick people. Quarantine is done on healthy people who are suspected of carrying infection. ऐसा मान लो कि let's say you go to some other country and state and they think you have chickenpox, they will quarantine you till maximum 21 days, because for chickenpox it is 21 days. But if they are sure that you have chickenpox, then they will isolate you for 6 days. For chickenpox it is 6-day isolation. So isolation 6 days, quarantine till maximum incubation period. Okay, I hope you will remember it. This is the image of Sapna, which is a mascot of leprosy program. In the leprosy, there is a program SPURS. SPURS means magical touch. It helps in early identification and acceptability of patient. So this is Sapna, the mascot for leprosy program. And this is the logo of NICUST program, or National Leprosy Eradication Program. Now when I saw this logo in one of the class, students said, sir, it has both Congress and BJP together. So this is the NICUST logo. And if they ask you MENA, MENA is a mascot of UNICEF. So in MENA, you can see a parrot, that is UNICEF. But in NICUST and in Sapna, you will just see the child with school bag and all, no parrot. So Sapna and MENA are there. I hope you will remember it. In the health education model, we use the thing mnemonic, we can use AMMA. First we do in the health awareness. After awareness, we do M for motivation, and after motivation we take action. So this is known as social awareness model. Social awareness model is AMMA: awareness, motivation, action. Okay, 3 things is there. There is another model known as medical model, in which we tell the patient what to do, what not to do. This is motivation model, AMMA. AMMA is the motivation model: awareness, motivation, action. Then there is social intervention model, which says that if government will keep the metro clean, people will not automatically spit on it. So government can also control disease. We need not to be blamed again and again. This is social intervention model. Okay. So what are the 3 models? Medical model, when doctor teach. Motivation, when people decide by awareness, motivation, action. And last is when government can save some people, that is social intervention model. Okay. So This is the questions. Now, two last question we want to do from here. One is about dependency ratio. I hope you all know. In the dependency ratio, young age people are written below. They are the one who are earning, and dependent people are written above. So they can give you some small numerical on calculation of dependency ratio also, which I am sure you can do. Now the question is that when the country will get demographic dividend or bonus. So देखो, demographic bonus is a good news. And when the country will have good news? If there is more dependent or less dependent? If there is less dependent people, that is a good news for the country, na? So for demographic bonus, dependency ratio should decrease. Now the question is, how will you decrease dependency ratio? To decrease it, we have only one option. Let's produce less children. If we will decrease this population who are less than 15 years, then our dependency ratio will decrease. So for demographic bonus or dividend, dependency ratio decrease. And how can we decrease it? By decreasing fertility rate. So if dependency ratio and fertility rate both decreases, we get demographic bonus. But when we will get demographic burden, this is one of the MCI question. बर्डन कब होगा? देखो, बर्डन मतलब बूढ़े लोग ज्यादा हो गए, तो बूढ़े लोग ज्यादा हो गए यानी डिपेंडेंसी रेशियो बढ़ गया। और बूढ़े लोग के साथ साथ और कौन है जो डिपेंडेंसी रेशियो बढ़ाता है? बच्चे 15 साल से छोटे। तो बर्डन तब होगा जब फर्टिलिटी रेट बढ़ेगा। अगर फर्टिलिटी रेट बढ़ गया तो 15 साल से ऊपर वाले ज्यादा हो जाएंगे, और 15 और 65 का जो कंबाइंड न्यूमरेटर है ये बड़ा हो जाएगा, तो डिपेंडेंसी रेशियो भी बड़ा हो जाएगा। यानी सीधी सीधी बात है, कंट्री को गुड न्यूज तब मिलेगी जब फर्टिलिटी रेट कम होगा। बोनस इज देयर व्हेन फर्टिलिटी रेट इज लेस, एंड ड्यू टू लेस फर्टिलिटी रेट डिपेंडेंसी रेशियो इज लेस। दैट इज बोनस गुड न्यूज। बट व्हाट इज द बैड न्यूज फॉर कंट्री? व्हेन इज द बर्डन? Burden is when both increases. Fertility rate increases, and a result of fertility rate, dependency ratio also increases. So we will get the bonus if both decrease. We will get the burden if both increase. So burden, both dependency ratio, fertility rate increase, bonus, both decrease. Okay, I hope you will remember. Now they can ask you to calculate relative risk or attributable risk or odds ratio. Calculating relative risk is very easy, because relative risk is simply incidence in exposed by incidence in non-exposed. And if you label it as A, B, C, D, A and C are here in the first left-hand side column, and relative risk incidence in exposed by incidence in non-exposed, it will simply become A by C. But you will mark it as A by C only if their A plus B is also 100 and C plus D is also 100. If exposed and non-exposed are equal, only then relative risk is A by C. Otherwise, relative risk formula will be A by A plus B by C plus D. But mostly in exam, when they give it, A plus B and C plus D, they are equal. So they cancel out. And final formula become A by C, like here 6 by 12. 6 by 12 means 0.5. So that will be the answer, 0.5. If they ask attributable risk is exposed minus non-exposed by exposed into 100. Do remember the formula. So in place of exposed minus non-exposed by exposed, we can write A minus C by A into 100. And in this case, if you do A minus C by A into 100, it will come 100%. So that is attributable risk. Now, in the formula of attributable risk, we are writing exposed. If you change the word exposed to places with population, exposed is changed by population. See? So AR become PAR. So AR is exposed minus non-exposed by exposed. PAR is population minus non-exposed by population into 100. Okay, so these three formula always remember, and they can ask it again. We can insert IUCD till 6 week or 8 week maximum. Okay, and what is the most common cancer in women in India? That's not cervical cancer, it's breast cancer. Most common in the genital part is cervical, but overall breast cancer is common. Why? Because prevalence is incidence into duration. And female who develop breast cancer, they suffer for 10, 15, 20 years, and they don't die so easily. So because their duration is more, so at any time if you measure the burden, more people will be having breast cancer. Similarly, if they ask what is the most common cancer of world, most common cancer of world is not lung cancer, it is also breast cancer. Same answer. Cancer in women of India and world is same, because Lung cancer people, they die within 1-2 years of diagnosis. Breast cancer, they survive for longer duration, so their burden is high. If they ask most common cancer in male of India, I hope you all know what is that. Oral, lip and oral cavity cancer, क्योंकि ऊंचे लोग ऊंची पसंद मानिक चंद, और बोलो तो बोलो जुबां केसरी, क्योंकि मुंह में रजनीगंधा कदमों में दुनिया. And this question has come that if someone has lip oral cavity cancer, how will you detect it? For screening, we put 2 fingers, one inside, one outside, and we palpate. If it is rough, it is cancerous. If it is smooth, that is cyst. So this is the way to diagnose, and this is the PAAR textbook saying that in both sexes it is breast, male or female, both combined also breast, and only female if they ask breast, not cervix. And in male, of course, it is lip and oral cavity. You can see it from the data. So these are some of the questions which I wanted to discuss in this session. Of course, there are many important questions. I cannot guarantee that I have covered every question which are going to come, but I am very sure that in your exam, 85% question will come from the topics which we have discussed. But if you want to be double sure, also go through one session which I took in expected question for July exam, expected July 2024. This is again on my this channel only, and in this July 2024 I have questions which are different from this topic which I have covered here. It will further help you there. But if you've done this much of question, you are ready to rock PSM part of the exam, because we have covered all the important topics which we discussed in the front type. Plus, we are ready with latest pattern. So don't be scared with your exam. In next 5 days, do 300 question daily, especially year-wise PYQ, and you will rock it. If you have any doubt, any question, anything you want to ask or share, feel free to write it. Anemia wala direct indirect question bana dena. Okay. Janvi S has a question. This anemia, this is a question which come here. So one thing I can tell you is the tetanus vaccination before going there. So in case of anemia, which one is direct cause of maternal death, they ask. And some of the teachers, they wrongly teach that anemia is the direct cause of maternal death. But PAAR has directly written that indirect causes include anemia. So anemia is not direct cause of maternal death. Malaria is not direct. Heart disease is not direct. What are the direct cause of maternal death? Direct causes are ectopic pregnancy, embolism, anesthesia related death. So ectopic pregnancy, embolism, anesthesia is there. Not anemia, malaria, heart disease. So which one is direct cause? Direct cause will be embolism, because heart disease, anemia, diabetes, all are written in indirect cause. Okay, so these are indirect cause. Now, rabies, and Janvi is asking for rabies, and of course, Dr. Med student saying knowledge plus entertainment is Ashwani Ranjan. Thank you, thank you. Your appreciation makes my mood very good. Thank you for that. Let's come to discuss tetanus first. So in the case of tetanus, this is the PAAR textbook guideline which I have taken directly. Remember this thing, that if it is less than 5 years, we will only wash, do no other thing. Whether it's clean wound or dirty or clean wound, doesn't matter, only wash. If it is 5 to 10 years, we will give only DT, whether clean, dirty, doesn't matter. This part is clear or not? Tell me yes. Less than 5, only wash. 5 to 10 DT. But if the patient is having this thing, let me teach it here. If it is more than 10 years, and it is clean wound less than 6 hours. So more than 10 years, less than 6 hours, we will give DTTT only. No need to worry. But if it is more than 10 years and other wound are forgotten, in that case, we will give TT plus TIG. So what I'm trying to tell you is, it's not so difficult. It's very simple. Less than 5 years, wash. 5 to 10, DT. That is done. More than 10, if it is clean wound, we will give DT. So we never give tetanus immunoglobulin for clean wound. But if it is other wound and more than 10 years, then along with DT, we also add tetanus immunoglobulin. Okay. And if any patient come with bhoola, forgotten history, so we will give so many vaccine that now he will not forget. So forgotten history, full course of TT is given. Forgotten history, do remember, always full course of TT is given. But if someone is clean wound and forgotten history, we will give full course. If someone is other wound and forgotten and other wound, then we can add immunoglobulin. Okay, let's revise it one more time. This is what Park is saying, that within past 5 years, if someone came, we will do only wash, nothing more is required. So within past 5 years, nothing more. Okay, 5 to more than 5, less than 10. More than 5, less than 10, what we do? More than 5, less than 10, we do one toxoid. No problem. So till 10 years, it is same. If it is more than 10, then there is two things that can occur. One thing, it is clean, we will give more than 10 clean wound, only toxoid. But if it is dirty, other category, more than 10 years, we will give toxoid plus immunoglobulin. Okay. And F is there. Full course only when forgotten, double F. Full course forgotten. So toxoid complete course if it is forgotten and clean wound, and toxoid complete course plus immunoglobulin if it is dirty wound and forgotten. Let's do some question on it to make it much better. The question is, 32-year-old male is there. He had TT in 25 years of age. And now he is coming to you with a crush injury, dirty wound. So what is the gap you have to find? 32 minus 25, 7-year gap. 7 years, what do we give? We give only DT. No matter whether it is clean or dirty, we give DT. Let's do one more question. If the patient has clean wound, less than 6 hours, TT taken 10 years back, what is the next management? Clean wound less than 6 hours, TT 10 years back. This was NEET question 2023. What will you give here? So because here it is clean wound, history is, remember, no matter it's 10 years, 20 years, always the answer will be DT. But if I change the question and I ask 10 years back TT taken but crush injury, again the answer will be DT because it's not more than 10 years. If they ask more than 10 years and crush injury, then only we will add immunoglobulin. So remember, immunoglobulin is added only in two cases: if it is more than 10 years or if it is forgotten history, and we add PIG only if it is other wound, not in case of clean wound. In clean wound, we never add immunoglobulin. Okay. So I hope this part is clear. If it is not clear, feel free to ask. It's not so confusing. Always remember, less than 5 years, wash only, 5 to 10, DT only. Then if it is clean wound, more than 10 years also, we give DT only. If it is crush wound, more than 10 years, then along with DT, we add tetanus immunoglobulin. And full course only if forgotten. Okay. So only in case of crush injury or other wound, we add immunoglobulin, not in case of clean wound. Now let's talk about rabies. In rabies, if it is pre-exposure, like in veterinary doctors and all, they already know they have the work to do sex of dog. And if any dog do not like the partner, whom they will bite? The veterinary doctor. So they should take pre-exposure on 0, 7, 21 or 28, 3 days. This is pre-exposure. And let's say you took vaccine and a second bite occur post-vaccination. So if post-vaccination there is second bite, in case of second bite, you need to take 2 doses, 0 and 3. And if you talk about the normal thing which we give, post-exposure, someone is bitten by dog, which regime should be preferred? Intradermal is preferred, because in intradermal, we give 0.1 ml 2 arm on 4 day, 0, 3, 7, 28. So total dose is only 0.8. That's why intradermal is preferred. But when we talk about IM regime, in IM we give 0.5 ml on 0, 3, 7, 14, 28. So total dose become 2.5. There is a lot of wastage of vaccine in IM. So we prefer intradermal, not IM. Last thing is that if डॉग केम और लपलपा के स्मूच देके चला गया, गिव यू लिप टू लिप स्मूच, इट इज कैटेगरी 1 और कैटेगरी 3? It is category 3. Category 3 if it is smooch on mucosa, licking mucosa. This is category 3. Second, dog came and scratched your face with no bleeding. That is also category 3. Scratch on face is also category 3. Third point, if bat bite occurred, चमगादड़ काट के चला गया, so bat bite is also category 3. And if there is a scratch with minor bleeding, no matter it's minor or major, if there is bleeding, it is category 3. So category 3 is 4 thing. Do remember, first category 3 is licking on mucosa, lip to lip kiss. Second is scratch on face. Third is bat bite. Fourth is minor bleeding. These all are category 3. And in category 3, along with rabies vaccine, we give human immunoglobulin. And what is the dose of human immunoglobulin? 20 international unit per kg. We give it half dose around the wound, half dose IM. So in this 4 we add immunoglobulin. In category 2, which is scratch without bleed, we don't give immunoglobulin. If there is no bleeding, only then it is category 2. If there is minor bleeding, also category 3. Do remember, minor bleeding goes to category 3. So scratch without bleed, we will give only rabies vaccine. So if your neighbor fully vaccinated dog came and scratched you with bleeding, fully vaccinated neighbor dog, will you give vaccine only or immunoglobulin or only wash? Dog is fully vaccinated or not, it doesn't matter. We never focus on dog vaccination status. Whether it's vaccinated or not, we consider it as unvaccinated. And we will always give human immunoglobulin if scratch is causing even minor bleeding. Whether the dog is vaccinated or not doesn't matter. Okay, so I hope all the important topic which you wanted to know and discuss is done. Still, if you have anything to tell, feel free to answer it. Mohammad Sanawaz is correct. 20 for human and 40 international unit for horse immunoglobulin. Okay, so immunoglobulin we always give human, because horse immunoglobulin can cause anaphylactic shock. Even in people like me, you will give human immunoglobulin. Okay, so I hope everything is clear. Feel free to ask your doubt or question on my WhatsApp number, and enjoy this last 5 days of your game, and don't think much about the result. Enjoy the moment and do your work daily of 300 question practice, PYQ year wise, and you will rock. Okay, so thank you so much. Hasta la vista, dasvidania. Love you all. If you have any issue, feel free to come and let me know. Bye. Thank you so much.